Go live now. A very warm good morning, good afternoon, and good evening from the WHO Regional Office for Europe. I'm Lydia Lazari, the Regional Advisor for Mental Health and Wellbeing here at the office in Copenhagen. And on behalf of our WHO team, I give a very warm welcome to everybody. If many of you were with us yesterday, you would know that we had a very interesting day, and I can promise to all the participants that we will have as exciting a day of today. Yesterday, we talked about the why and the how of we made the case for integrating mental health in primary health care. We looked into the scientific evidence. We looked into how can policies enable integration of mental health into primary health care. And we heard also from some good practices from different countries. And mind you, the countries that we involved were countries of the WHO European region, but we were very happy to see that the participants came from all over the world. We have an exciting program today as well. We'll start talking about capacities and skills for the primary healthcare workforce. Then we'll go to talk about sustainable financing, how we can sustainably fund and finance mental health integration into primary healthcare. And last but not least, we also want to innovate. So we'll talk about how to harness digital technologies at the primary care level when it comes to integrating mental health there. Without further ado, I will now pass the floor on to two colleagues from WHO Europe, Dr. Cassie Redlich, Technical Officer for Mental Health and Wellbeing, and Dr. Margarita Langins. It's a technical officer at the Human Health Workforce Development Team in WHO Europe. Over to you, dear Cassie and Maggie.
Good morning, colleagues. Yes, my name is Maggie Langans, and I'm the Nursing and Midwifery Policy Advisor here at the WHO Regional Office for Europe, working with the Health Workforce and Service Delivery Team.
Thanks, Maggie. And my name's Cassie Redlich. I'm a technical officer with the Mental Health and Wellbeing Unit here at WHO Europe. I want to warmly welcome all of you to our second deep dive session of the conference, where we're focusing, as Lydia said, on the critical area of workforce education and training as one of the key strategies for integrating mental health into primary healthcare. And I think from yesterday's discussion, we saw in the questions that came in, we saw on the chat, that this is an area that's really interesting to you all. So I'm glad that we can do a deep dive into the topic. And it was clear, I think, from what you were saying and what you were asking, that there's a real understanding that actually we can't talk about scaling up mental health in primary healthcare if we don't have a workforce that are trained, that are confident, that are motivated to deliver services, and also if they're not supported through policy, through regulation. So I'm hoping that today, with all our speakers, we can both acknowledge that there are these barriers, but also that we can identify some strategies to address them. And we have many examples of how that's been done in many countries. So we have a keynote speaker as our first speaker today. He's going to talk to us about a WHO resource that really focuses on one strategy, which is pre-service training for doctors and nurses. And then we're going to hear from our panel. They're working across 4 different countries in our WHO European region. And they're going to talk to you a bit more about the strategies that they've been using in their respective contexts.
But a few things about logistics, or some housekeeping. Please use the chat to introduce yourselves, share your examples from all over the world, because we know it's a very international group. But for questions for our speakers, please use a different modality, which is the Q&A at the bottom of your screen. So please use that. We're watching it, and we're going to look for some of those questions that we can ask our panelists at the end. Another housekeeping point is that when we do have a presentation, you will have the option of watching it in English or Russian. So you just have to click at the top of your screen on, there will be 2 tabs, and you choose one that works with your language. Also, please make sure you use the interpretation button at the bottom of your screen to follow if you would like to follow in English or in Russian, okay? I think that's all for now, Cassie. I think it's now time to turn to our keynote presentation that will set the scene for us. We're really delighted to have our colleague, our former colleague, Dr. Brandon Gray, a global mental health expert, and he formerly worked with our Department of Mental Health and Substance Abuse at WHO headquarters in Geneva. So over to you, Brandon.
Thank you so much, Maggie and Cassie, and hello, everyone. It's a pleasure to be here with you. I'm just going to share my screen. Are you able to see that okay? Perfect.
Yes, we are.
Yes, so thank you so much for the opportunity to share with you a little information about a resource we developed when I was at WHO headquarters about educating medical and nursing students in providing mental, neurological, and substance use care in pre-service education. I'll define what that term means in a little bit, but I'll just first set the scene very briefly. I think this is information many of you already know, but just to set the stage, the focus of this is really about addressing this huge gap that we have between the number of people globally who are living with mental, neurological, and substance use conditions, and the fact that most of those people go without receiving any sort of effective care. And there are many reasons for that gap, but one of the key challenges that we're talking about here is the lack of a trained healthcare workforce that's able to actually provide the quality and effective mental health care. And the numbers are actually really stark if you think about it. Nearly half the world's population lives in countries with fewer than one psychiatrist per 200,000 people. And then the shortage of mental health nurses, neurologists, addiction specialists, it's even more severe. So this is a problem that specialists alone just cannot solve. On the other hand, what we're talking about here in this conference is the fact that primary healthcare workers can be a good solution. The fact is that they're the first point of contact for people with mental, neurological, and substance use conditions in the health system most often. And so they're a really valuable resource. Unfortunately, we hear many of them reporting that they graduate without the competence or confidence to actually provide that type of care in many countries. So what do we do about that? Well, for WHO, the focus has been on upskilling or training primary care workers who are already in their professional careers and how to provide this care. And WHO has done that primarily, at least since 2008, through a program called the Mental Health Gap Action Program. I'm sure you've talked about it already in this conference. Many of you are probably already using it or very aware. Just to quickly summarize for anyone who's unfamiliar, MHGAP was launched in 2008, and over the last 16 years, it's been developed to be a suite of clinical and operational tools focused on training health workers and reshaping health systems to provide mental, neurological, and substance use care. It's been implemented in over 100 countries and is founded in a regularly updated set of evidence-based guidelines. So in hundreds of places in the world, there are in-service trainings happening using these MHGAP tools and making a real difference. But still, this gap between the number of people with these conditions and the lack of services persists. So we have to ask the question about what more could be done. Well, one answer that WHO's considered was to address the problem earlier, before health workers even enter the system, before they enter their careers, by developing the right skills, the right knowledge, and the right attitudes for mental, neurological, and substance use care during pre-service education. Now, what is that pre-service education? It's a bit of a strange term, maybe unfamiliar for some of us. What it is really just the structured learning that takes place before a health professional enters practice. So learning that takes place in universities, in nursing schools, and medical faculties. The rationale for focusing on skill building during pre-service education, I think, is quite clear. So it builds early confidence and competence in providing M&S care. So it's not a new task when people enter the profession. It's already been part of the foundation of learning. Pre-service education is also a really good way, according to scientific evidence, to reduce stigma and address stigma. It also emphasizes this idea that mental health care is not just for specialists or somehow separate, but it's actually part of our overall health. from day one in a health worker's education. It also creates this sort of sustainable pipeline within a country, because every graduating cohort of health workers would then have a foundation to provide quality mental health care that then can be built into in-service training and continuing education. And I think critically, in this way, it complements rather than replaces in-service training and continuing professional education throughout the career pathway. So in 2022, WHO decided, and actually it's something in process for a long time, thinking about this topic. And we started a process, though, in 2022 to develop a guide to actually support universities and ministries to reshape how curricula are used to educate health workers in mental, neurological, and substance use care. So after doing quite a bit of consultation with educators, with medical regulators, with people with lived experience, with students themselves, we decided that this guide should be developed, and we were informed that it should focus on doctors and nurses, firstly, as kind of the main cadre of providers who would be able to address this issue. So in developing the guide, we did quite a bit of review, 33 different academic papers, 63 different curricula across the world, interviewed 50 different key informants, held 2 global consultation meetings, and actually consulted in writing more than 200 different experts and people with lived experience. At the end of the process, the guide you see on the screen is what was launched last April, and it's available with the QR code, and we'll also share some of the links to it in the chat. So what is this guide? Well, it's designed to be, we hope, practical. So it's not a policy document. It's more of a hands-on tool that you can adapt and take and choose pieces that work and fit for your context. So it's definitely not a one-size-fits-all approach. It does use a competency-based approach, so it focuses on making sure students can demonstrate the right knowledge, skills, and attitudes in providing quality M&S care, and actually lays out how you can actually assess that competency. And it defines those core competencies as well that we felt were relevant for doctors and nurses in most contexts, in most countries, based on the different consultations that were undertaken. So the guide's organized around 4 main chapters after the introduction that's setting the scene. The first is, of course, preparing, planning, doing things like situation analysis, developing a work plan, having a working group. The second is about defining those competencies. So we lay out what the competencies are, and then a process for how one can choose those competencies based on the tasks that health workers are expected to do in that setting. And then there's a chapter on how to actually develop a curriculum around those competencies. So setting the learning objectives, understanding how the competencies are actually going to be assessed and how they're actually going to be trained, and giving different options from different examples across the world. And then laying out also how educators can be trained. And then there's a chapter, of course, on now you have a curricula, how do you actually implement it? And how can you overcome some of the common barriers that exist with changing curricula? So at the core of the guide are these 12 core competencies you see on the screen. And these are competencies that through the process of developing this guide, we were informed through consultation that many people feel most medical and nursing graduates should develop to provide effective, rights-based, person-centered mental, neurological, and substance use care. Now, in the guide we were developing, we were focusing on first-degree education, or in some settings, you might say undergraduate education. It's education that's setting kind of the first foundation before doctors and nurses specialize. And these competencies are largely informed by and in line with MHGAP clinical guidance. So that's really the heart of the guide is MHGAP, and that was on purpose. We wanted pre-service education to sort of build this foundation that MHGAP in-service training could then reinforce. So each competency is broken down into specific attitudes, knowledge, and skills required for quality mental health care. This is just an example on the screen of one of the skills, foundational helping, and it shows how there's a table in the guide and the chapter on defining competencies that actually lays out the attitudes that apply, the knowledge that applies, the skills that apply, and then there's later information about where you might find ways to teach on these different aspects. So that comes in the enhancing the curricula chapter, where the 12 competencies are really just a starting point for building learning objectives and structuring a curriculum's content. So in this section, it's actually going through the different approaches you can use to change attitudes, to build knowledge, to develop and apply those skills we talked about, giving a lot of different examples from different contexts, and how to actually take that curriculum and put it into reality. On the screen here, I'm just highlighting one example from the guide that's a part of a larger section. This is just an image from that section that describes the specific learning objectives, the teaching methods, the assessment methods one could consider to try to develop the right attitudes, knowledge, and skills to have competency in managing alcohol use disorders and drug use disorders. This is just one example that's kind of elaborated in the guide to kind of show how you can go from choosing a competency to actually developing curricula around it. And there's a number of different examples like this. And then when it goes to actually implementing that curricula, the guide tries to provide strategies for what you can do in a well-resourced setting or in a resource-constrained setting, and also at different, we can say, different levels of implementation. So very, very broad or very wide implementations, such as changing curricula at a national level, or, for example, just changing one course within a single university. We try to give some examples from both because we learn from people who are doing work at both levels or across the different levels. So this is quite integrated into this implementation chapter. So this is the guide. What does it mean for people in this room? Well, I think many of you are the key people in shaping the health workforce in your countries. And so I think there's a number of things you can do, I hope you can do with this guide. I think first, of course, is to share the guide with educators, with universities, with ministries of health and education, and try to just make a change in how we're educating doctors and nurses in mental health care. Second, integration in existing work. So many of you are probably already running programs on integrating mental health care in primary health care. You might be running an MHGAP program, for example. You could consider whether there are universities or nursing schools you could engage upstream as part of that project, even as a pilot, to try to implement some of this competency development in the educational system. Third, I think policy advocacy. So I hope the guide could be useful in making a case for strengthening national curricular requirements, right? Changing licensing exams or accreditation standards, holding a workshop on that topic at least. Fourth, we did feel the guide could be useful for research and more implementation research, because that can be kind of an entry point to pilot small changes in curricula and build towards larger change and improvement over time, particularly in a setting where there might be resistance to making a lot of changes to curricula. This can sort of demonstrate proof of concept. And there's some examples actually in the guide of places where that's been done to sort of have an entry point to changing curricula. So that's the guide. I really hope it can be useful for you, and thanks a lot for your time. I just want to end by saying I think it's really important that we try to ensure that every doctor and nurse, no matter where they're practicing, is equipped with the skills, the knowledge, the attitudes to provide compassionate, competent mental health care. And I think if we address this topic, we truly can improve the lives of millions of people. So I hope this guide can be one small part of making that change. So thanks a lot. If you have any questions, please feel free to contact me, or I'll also be around. So if there's any questions, I'll try to answer in the chat. Thanks so much.
Thank you so much, Brandon. That was a really nice way, I think, of setting the scene, and making sure that the audience knows about some of the things that already exist. But I think we all know that it's one thing to have resources and tools, and it's another thing to implement those. And so I think it's going to be perfect to now shift into the country experience. So what's actually going on in the countries? And we have our marvelous panelists. They are here on your screen. They come from 4 different settings, 4 different contexts, and they're going to talk to us about some of their experiences doing this work in their own settings. So without further ado, I'm going to introduce our first speaker. Nikolai Nagai is the World Psychiatric Association representative for Eastern Europe. On top of that, he is a long-time champion of mental health reforms in Kazakhstan, also a former colleague of ours at WHO Europe. It's a real pleasure to have him talk to us today. He has a multitude of experiences. Nikolai, I hand over to you. The floor is yours.
We don't hear you, Nikolai.
I'm sorry, disconnect. Yes, thank you for the question, dear Casey, and the opportunity to share some experience. In very simple terms, our experience in Kazakhstan shows that integrating mental health into primary health care truly works when three things change. At the same time, team roles, geographic access, and financing rules, while MHGAP provides the clinical framework. Our PHC model was built on a multidisciplinary team and task sharing. The PhD doctor provides prevention, diagnosis, and treatment of common mental disorders and coordinates the team. Psychologists and social workers conduct screening, outreach, and support for at-risk groups, taking social determinants into account. Nurses were empowered to run independent consultations and make nurses' diagnoses. They immediately reduced the burden on specialized services and made mental health care a first entry point in regular polyclinics. Territorial access was improved through network restructuring and a one-stop service principle. Instead of 47 large psychiatric and addiction hospitals, we created 17 mental health centers. At the same time, 83 urban primary mental health centers were opened within city polyclinics, and 200 rural mental health offices were established. At the PHC level, patients gained access not only to consultation, but also to referral pathways, psychological and social support, and prescription of medicine. The financing model was adjusted to support outpatient care. The overall mental health budget increased 1.7 times between 2017 and 21. Outpatient medication funding increased almost 1.6 times. This is critical because without access to medicine, integration in PHC cannot be sustained. We used MHGAP as a practical operational standard to build workforce capacity. Through cascade training from 2018 to mid-2022, we trained about 20,000 PHC professionals. MHGAP Interventions Guide was integrated into undergraduate and postgraduate education. The most visible result was a shift in patients' flows and a reduced depend on inpatient care. During the period from 2018 to 2021, the number of psychiatric visits at the urban PHC level increased 3.8 times. At the same time, psychiatric bed capacity was reduced by 20%. And one-year admission rate is decreased by 28%. In practice, this means more active detection and treatment at the PHC level, and a reduction in unnecessary institutionalization. Our main conclusion, integrating mental health into PHC is not a single training or a single policy order. It is a systematic reform. PHC team, territorial access, financing changes, with image gap serving as the clinical backbone for standardization and scaling up competence. Thank you.
Thank you, Nikolai. And thank you really for starting us off on a very good step here in articulating so clearly that it's not just about the education and the training of the workforce, but those enabling aspects like financing, like the service design, and having this health workforce work so closely together in primary health care to support the delivery of MHGAP. Our next speaker, I'm delighted to introduce, is Karina Beinerte, Dr. Karina Beinerte, and she is a child and adolescent psychiatrist from Riga, Latvia. She is the head of the Child and Youth Mental Health Center at the Children's Clinical University Hospital. Karina, you've been developing a very innovative service model in Latvia, which fills a gap across primary and secondary care services for young people experiencing substance use and addiction issues. And it would be great to hear from you how your efforts to develop this more community-based service and has led to roles and functions for the team, and how you're building the competencies of the staff to deliver these services more collaboratively with primary healthcare and in the community, but also with each other. Over to you.
Thank you, Maggie. So yeah, I'm going to be sharing today our experience with the setting up new team, which is a multidisciplinary team, and it is set up to treat adolescent substance use problems. The team is government funded, and it's aimed at the group of young people who already have problematic substance use and addiction. So it is more problematic side of the population. The team is based in Children's University Hospital, so essentially it is a secondary care level, but the focus, how we set up and design the team and the service is very strongly focused on community and collaborative working. So the team has 6 full-time equivalents: nurses, occupational therapists, clinical psychologists, addiction psychiatrists, social worker, and physiotherapist who acts as a sports coach, and we have a mentor with lived experience as well. The team serves the capital city and the nearby regions, and it is mainly related to the fact that we offer outreach and the home visit element, and we wouldn't be able to offer wider region. Referrals we receive from the families themselves, from GPs, from other addiction psychiatrists who don't have the multidisciplinary team around them, and from hospital emergency department as well, if the young person has been taken there with intoxication. So the collaboration, I'll talk about the collaboration element in a bit, how it works in our team, and what we did to kind of really establish as part of the team. The caseload is 33 patients around. It really depends. If there are more difficult patients, then we have a bit less. And if more difficult, then easier, then more. So the innovative elements that I wanted to stress and talk about are the first one is the case management. We didn't have case management in mental health in Latvia. It is not a concept that we are familiar with. I know it's in other countries very familiar. So to set it up in our team, firstly, the team was without much experience in such service in mental health, with some experience in mental health, but not a lot. So it gave us opportunity to really teach them from start. We taught the concept, what it is to case manage, and then supported through formal and informal supervision to really establish the practice, what it is, and really it is assessing and then kind of leading through the treatment process, the patient care. With the home visits, which is another new element, we invited a person who offered home visits in another service, which is palliative care in our hospital, who then taught the main concept, and then adjustments for our team were made collaboratively in the team. So we basically explained to them that because there's no one else in mental health in Latvia that can teach them, they have to create and hone the concept of home visits in substance use, and it was done in team meetings. Then another service new innovation was cross-sectoral collaboration that we really involved in design, in initial design. So we basically wrote the process, the assessment and treatment process, how we wanted it to be. And one of the assessment elements was to map the team around the child, which involves if GP is very closely involved, we would invite GP to the meeting, social workers, probation officers, other specialists around the young person and family. So we would map them and then invite for the initial team around the child meeting. And then in more complex cases, we would have regular meetings with this team around the child to work collaboratively. Again, this is a new concept. So we taught the concept initially, we taught what it is, and then we got a formal training in it as well, how to lead these meetings. So what we did to train the team, we also offered the evidence-based method that they could use in treating these young people. This all required several protected hours a week for the team that was set aside, that whole team engaged in a program that we developed together. And the program was also changing a little bit as we recognized new needs for the team, for the knowledge. So I've been trying to widen the role and enhance the role of the nurses and allied health professionals in mental health in Latvia for a while, and I've learned that what it requires is that basically the easiest way how to change the culture and change the more subordination focused care to more collaborative is really to set up a new team and teach them from start how to work together, and then support them through mentoring and supervision. So far so good. I hope I will be able to report later on as well how we are going when the service is with experience. Thank you.
Thank you, Karina. I mean, it's just a very beautiful example of thinking about how we move from training education alone of doctors and nurses to expanding, think about what does it mean if we have multidisciplinary teams that are working in new ways with different roles and functions. How do we teach case management? How do we teach about a team approach that has all these disciplines? It's a lovely experience and another example of the innovation that is going on in Latvia. So thank you. I'm sure there will be many questions to you. And I want to remind people that we will have time for questions, a few questions at the end for our panelists. And also for Brandon. So if you have questions specifically for them, please put them in the Q&A function so we don't lose them in the chat. So we're going to move on to Besim Nouri, who is a health specialist and manager in the Health for All project in Albania. Besim, my question for you, you've also used some existing tools like MHGAP in Albania as a starting point for building mental health guidelines and training for primary healthcare. But then you've been, I think, really innovative in the strategies that you've used to consolidate that training and adapt very well to the sort of changing policy environment, workforce changes in the countries. Can you tell us a bit more about the work you do through the Health for All project?
Thank you, Cassie. Hello, everybody. Thank you very much for inviting me here. It's a real privilege to share our experience with such an interesting and very broad audience. I'm the manager of Health for All project, which is a program in support of primary healthcare in Albania. It is a project funded by the Swiss government, but implemented and guided technically by the Swiss Tropical and Public Health Institute of Basel. So I'm based in Tirana and I have a team. We worked since 2017 with many primary healthcare services and centers in Albania. I will focus on what do we do in mental health, because we have also many other activities related to NCDs, etc. But in mental health, we work very closely with national authorities. The Ministry of Health of Albania has an action plan for mental health 23-26, and we operate in that framework. So we implement some components of that plan. What we have done in the recent 3-4 years? First of all, elaboration of a guideline for management of mental health disorders in primary health care to be used by general practitioners and nurses and psychologists at this level. The second thing, this document was approved by the Ministry of Health, and so we started to disseminate it in many health centers of Albania. Of course, the document is in electronic format, accessible to everybody. But in addition to that, we have organized a continuing education cascade program by first training of the trainers. So the local health authorities select physicians and nurses and psychologists where they exist from primary healthcare centers, and we train them as in these guidelines for management of mental health disorders. And then once they're back in their health centers, we continue our support to organize the so-called peer groups, which is an additional continuing education tool and is accredited by the respective agencies in Albania. So they continue further to discuss, to teach to their colleagues about the guidelines, to work with them, to discuss with them about that and try to implement as much as possible. The other element we have worked in is to support the interprofessional collaboration in primary health care focused on mental health. The government of Albania has decided and has acted recently. They have hired psychologists and social workers in primary healthcare teams. So 1/5 of the health centers of Albania presently have a psychologist. Now the challenge was how to integrate their work with the work of the existing family medicine team, so doctors, nurses, and midwives, etc. So in that regard, we have also elaborated a manual to be used by the psychologist, how they can work, which is not a simple clinical tool, but also is used as a document for integration, for better definition of roles, for coordination activities, and so on. And of course, we are going also to continue our training activities with the psychologists. By the way, the psychologists operating in primary healthcare, they have really boosted the work of existing physicians and nurses because they bring a different perspective, and they also make them feel more confident in terms of mental health activities. In addition, we are working also to do some work with social workers, because they are also social workers, in order to combine the work of all these new resources at the primary healthcare level. Our guidelines, in fact, have been shared also with the Faculty of Medicine. We are using them not that at the undergrad level, as Brandon presented, but we are sharing the documents with the postgraduate training in family medicine. So the doctors could learn already in the Faculty of Medicine during their postgraduate training these new tools, clinical management tools on treatment of mental health disorders. So we are going to continue our activities in this regard. There are positive signs. I have to say it is work in progress. It is just the start. It is a good political will policy from the politicians to introduce that at the level of primary health care, but at the same time, we're also making advocacy for more resources because, of course, they have undertaken some measures and steps to employ more personnel, but still more needs to be done. And these continuing education activities should cover all the country because for the time being, this is a cascade that is ongoing. And then we'll move to the next steps, that is really how those things are implemented to evaluate, to make the assessment. So this is more or less, and I would be willing to answer questions. Thank you very much.
And I hope there will be some questions for you, Basim, because there's a lot there that you're talking about. I mean, it's that political will, but it's also, I mean, all the infrastructure that is needed and the expertise that is needed to develop those guidelines, to institutionalize, accreditation systems that reinforce and support the continuing professional development to take place and motivate our health workforce to engage with this learning in primary healthcare is just so important, and it's not to be taken for granted, right? And that expertise doesn't just sit with your physicians, but you're talking about social workers, you're talking about nurses, so you're talking about different health workers. So this is a really wonderful example from Albania, and I think everyone will agree with you that it's a work in progress, not only in your country, but in their countries. This is the journey that we as WHO are on with countries in this space. So it gives me great pleasure now to introduce our next panelist. Our colleague, we have Jorge Fasanha, a specialist in mental health and psychiatric nursing and a nurse manager in the outpatient unit at a local health unit, so a local primary health care center in Coimbra, Portugal. From Jorge, we've had some very interesting discussions, especially focused on nursing. What we know is that in Portugal, you've had a profound restructuring of mental health services, really bringing community mental health teams to surround the primary health care centers, to serve them and support them, with specialist nurses being in this role of coordinators. And what we've learned from you in our conversations is, there are these 10 mental health teams that serve 21 different municipalities. For me, what is really interesting is the important role that these nurse specialists play and these coordinators in supporting these community mental health teams to support primary health care centers. So I'm wondering, Jorge, if you can tell us a little bit about how these nurses work with family doctors and the staff in primary health care teams to support the continuity of care for service users.
Hi, good morning. I begin by thanking the whole health organization represented by Maggie for the invitation and the opportunity to share my experience. In the total of 26 primary healthcare units, each of the 10 community mental health teams is composed by 2 specialist nurses in mental health and psychiatric nurses. 2 psychiatrics, a social worker has a part-time, and Science November, a psychologist. Each team has a reference therapist to case manage, and this role being ensured in most cases by nurses, who is the responsible for the follow-up in the community and flexibly treatment in community with greater emphasis on the person and less on the disease. This model tries to keep as of the care in the community and with primary healthcare team, and is focused on better communication and coordination between primary healthcare and integrated healthcare with consultancies, meetings, and clear and effective communication channels, as well as benefits for individuals, for families, and those reports by professionals from various contexts. Continuity of care is operationalized through systematic coordination with primary health care and the social network and other community partners, allowing for more integrated and adjusted responses to the complexity of people needs, particularly those who suffer mental illness. In Portugal, mental health teams are paid to perform well. It is paid for by the Recovery and Resilience Plan, which is run by the National Coordination of Mental Health Policies and belongs to Ministry of Health. So, from an organization and managerial point of view, the reforms implies new ways of working in teams, like greater interdisciplinarity, management of clinical complexity, and the enhancement of preventive and psychosocial rehabilitation intervention. This is only possible because mental health is already integrated in nursing education before they graduate. So, mental health is not just a later specialization, but like a structural component of undergraduate nursing in Portugal. We have mandatory curriculum content that they have basic training, undergraduate degree. Mandatorily includes theoretical and practical curricular units dedicated to mental health and psychiatric nursing. Clinical teaching internships before obtains their bachelor's degrees. The students undertake clinical teaching in mental health settings where they develop interpersonal relationship skills like therapeutic communication and crisis management. The holistic care model, correct training focus on the heart of caring as a science that integrates psychosocial well-being and inseparable from physical health, preparing the general care nurses to identify early signs of mental distress. To enable patient management occur predominantly in the community, several support mechanisms have been implemented, like the community mental health teams and some programs for assessing of physical health of people with severe mental health disorders and assessments of comorbidities. The financing and investments are specific financial allocations intended to finance the implementation of mental health strategy, including strengthening of human research in the communities. These incentives for mental health teams in Portugal, particularly for integrated responsibility centers and community mental health teams, are based on compliance with the Team Performance Index. Some of the examples of these indicators focus on main dimensions like access, quality, efficiency, and integration of care. We have some examples like access, like monitoring of response speed, occupancy rating, and waiting timing for consultations or interventions. an example of quality care, like 30 days readmission rates for patient with inpatient or home hospitalization, user satisfaction, like evaluation the patient's journey, and professional satisfaction. In integration care, we have percent of direct admissions, increases efficiency and reduces emergency, and other examples. Nurses play a fundamental role in training other healthcare professionals, ensuring that the multidisciplinary teams know how to support patients effectively, safely, and humanly. This educational and leadership aspect in clinical practice is recognized as one of the main responsibilities. On the job training, nurses, often specialists or consultants, train healthcare assistants, medical students, and other healthcare professionals in procedures, patient safety, and quality care. And care training, they promote training how to welcome, empower, and refer patients and families, improving the experience of disease journey, and technical and practical teaching. To finalize interprofessional education, they participate in collaborative teaching, where nurses and doctors learn together to improve communication, teamwork, and patient-centered care. Thank you.
Thank you, Jorge, for that. And it's always very interesting to hear from Portugal, where we see nurses really educated to very high standard already at the bachelor education, a bachelor's level, so that they can actually be entering those roles very easily. And then on top of that, add specialisms that allow them to really dig even deeper into some of the expertise that is needed in mental health. So thank you for that. I think we're going to bring our panelists back and all onto the screen, because we have some questions coming in the Q&A. I am going to ask people who want to ask questions to our panel to, again, put them in the Q&A, but also if it is directed at one of the speakers, to make that very clear to us, because it may not be as obvious to us. If we can also get Brandon on the screen, that would be great, our keynote. And I think before we look to the Q&A, I just want to turn to our panelists themselves and explore with you what you found interesting. We've covered northeast, south of our region, our very big WHO European region. Are there things that you have learned or found interesting from what you've heard here amongst us from the different corners of our region? Does anybody want to sort of go first with a reflection on what they found interesting? Basim.
Okay, thank you, Maggie. Yes, I can start. In fact, it is very, very interesting to hear so many experiences and to see that there is such a variety of models, of the types of services and of solutions based on the context. Of course, I'm very impressed by the model of Kazakhstan, as they are moving somehow in the same way that we tried to do in Albania, but of course they have done that much faster, and probably they have injected a lot of money in that, which is very good. So they are showing that they are champions in primary healthcare, as historically has been the case. Yeah, but I mean, and also what Brandon presented is a very good document that we need to use, especially for nurses, and try to incorporate in our academic programs, because it is really necessary. Over, yeah.
Great, yeah. Karine, Nikolai, Brandon, do you have any reflections, Jorge, on what you've heard?
Thank you. It is very inspiring to hear teams and services in other countries. It really helps, kind of gives energy, continuing the work that we have started in Latvia. Well, I wanted to say that hearing Brandon's very structured presentation about the pre-service education has been very valuable, because it is the work that is happening a little bit, at least in Latvia as well, that the curriculums are being reviewed, and knowing about this document is very helpful. It will be used in Latvia, I can tell you. Thank you.
Yeah, it's very nice to hear the rich examples, but also that actually there is some very important guidance here that can be used and can be used in different ways, but can be definitely applied. So we don't really need to look for that evidence and that structure, but it's up to our countries to and our health systems to sort of interpret how to do that. Nikolai, do you have any reflections? And Jorge?
Да, да, огромное спасибо. Конечно, все выступления на этой панели были впечатляющими. И я участвовал в лоунче того руководства, которое представлял доктор Брэндон. Оно было впечатляющее. Мы тогда сказали в Казахстане: вау, наконец-то есть то, чему мы можем следовать. Чему мы можем следовать, и то, что у нас есть, потому что это было структурно, потому что мы очень часто искали сами, опираясь на многие-многие документы, это, конечно, эффективно. И, конечно, мне очень впечатлило выступление Карины в части того, что разные мультидисциплинарные команды для разных целей и задач, и их эффективность должна постоянно пересматриваться в зависимости от задач. То есть мы немножко шли по-другому, да, мы сделали команду и уже подгоняли задачи под них. Но здесь немножко другая ситуация, и, возможно, эта гибкость, она поможет в решении многих других задач наших. Ну и, конечно, BSIM, то, что тоже мне было интересно, мы пошли немножко с другого, то есть мы начали структуру, потом image gap, а здесь все наоборот, и это тоже очень интересный опыт. Огромное спасибо за вот эту панель и вот эти новые вещи, которые, для меня были открытием. Спасибо.
We might now go to one of the questions, and I'm not going to throw it to anyone. I'm going to hope that one of you would like to take it. So we have a question, and I think it's a really good question about many of you talked about multidisciplinarity. So bringing in psychologists, bringing in social workers, other specialists into primary healthcare. It's one of the strategies that we talk about in the policy brief. But this question is about, well, what do we do when we don't have those specialists who want to work in a primary healthcare settings? So would any of you like to talk about, and I mean, Brandon, maybe this could be for you, but others, because we are also talking about building capacities and competencies in our traditional primary healthcare workforce. So family doctors, GPs, nurses who are already working in primary healthcare. Would anyone like to comment on that aspect of building capacities for mental health work in primary care? And I think Brandon was nodding, and then we lost him.
I think he may have left.
But anyone else who is interested to take this one?
So I think Jorge's example is a really nice example of a solution where it is so the service is created around and between the secondary and primary care, right? So I was very inspired by Jorge's example, because in Latvia, it is problematic to create these wider general practices. So the GPs aren't very welcome of having the wider team around them. So I am looking at Jorge's example as something to talk about, and hopefully someone can hear me in the corridors of policy makers.
Did you want to follow up, Jorge, with any comments about that work? Because this is something that you did talk about. And I agree, I think it's a very nice example.
Yep. These were very interesting insights that reinforce the importance of the strategy that can also be used in the other countries, focusing on community and the impact of training of nurses and other professionals can have. And this is very, very important. So I think the specialist nurses can plan consultation meetings with family doctors and primary healthcare nurses, and which cases are presented that are analyzed and evaluated with intervention proposal by the mental health team, and which are carried out the primary healthcare team, like family doctor or nurses. And I think this allow these patients to assess mental health care earlier. This is very important. And without having to wait for a consultation with a psychiatrist or a specialist nurse, and even reduces the need for hospitalizations and keeping the patients at home. It is very important. Another skill that is worked on is the importance of developing an individual care plan. This should include clinical evaluation, social and family assessment, and we use the Camberwell Need Assessment Questionnaire, which evaluates 21 dimensions and should be used. And another example, it was the training conducted by specialist mental health nurses in some strategies like psychoeducation model or relaxation. I think this could be some strategy in education that nurses can be very important.
And I think it also makes it less lonely to be in primary healthcare, right? Sometimes we've had these, in some countries, traditions of very lonely family doctors with family nurses alone in primary care, taking on the weight of their community. And when you have these sorts of resources and you diversify the group of professionals that they can engage with and connect with and build relationships with, it's also very important to support a primary care model that is then attractive to the next generation of health workers. So I agree. It's very nice to hear this example from Portugal. We have, Cassie, a question that's also come up a little bit about, we're going to get into it in the next section, but perhaps our panelists can react to the structure of funding and reimbursement for multidisciplinary teams. When funding sometimes disincentivizes a multidisciplinary team, that's also problematic and unhelpful if you want to bring a team of health professionals around the patient. So what are some of your experiences with this? What you see works or doesn't work from a financial and a funding perspective to support this team? And then we have one more minute okay.
If I can say something,
Please go ahead.
Thank you, Cas. In the case of Albania, they are not paid. The personnel is not paid based on fee for services. They are paid based on a mechanism of capitation, and it's a bit modified. So practically, they have a kind of stable salary. This is how the government has created a certain sustainability of the workforce in that regard. So even the new psychologists that join the teams, they have their salaries fixed, so they have a certain security of their work. In addition, many drugs are reimbursed, the drugs for mental health treatment, but now you bring some solutions, and then you find ahead of you other problems that you need to solve. For instance, we are talking about primary healthcare physicians and nurses, but the doctors cannot prescribe in Albania for psychotropic drugs unless they have a kind of confirmation from the specialist psychiatrist. So they are asking now for more flexibility and less bureaucracies, etc. Probably this is because the health insurance fund wants to have some control on the costs, but yeah, that's another issue. But those issues probably will be discussed in the next session.
Okay.
Exactly, and that was a perfect taster, I think, Besim, for what we're going to hear in the next deep dive session. And these questions around financing, sustainable financing, but also access to medicines. I see that these have been big questions in the chat. We have a number of sessions left, so it's a perfect way of closing up and moving on to our next deep dive session, I think. So I think there's nothing more to say, but very huge thank you to all our amazing panelists, to Karina, to Jorge, to Besim, to Nikolai, to Brandon. Thank you so much for being here. Thank you to the audience. You've been amazing. We see how active everyone is in the chat and asking questions. Please stay with us for the next deep dive session. We're moving now to supporting scale up of mental health services through sustainable funding and financing. Many thanks, everyone.
Okay, everybody. Good afternoon, and welcome to this next deep dive session of the conference. Start with some introductions. My name is Dan Chisholm. I'm a mental health specialist in the Department of NCDs and Mental Health at WHO headquarters. I was also a former program manager on mental health in the European region, and delighted to be joining this mini conference on mental health and primary care. Over to you, Trin, just to introduce yourself, and then we'll ask maybe for the PowerPoint to be put up as well.
Hello, good afternoon to everyone. My name is Trin Habicht, and I'm Senior Health Economist from the WHO Barcelona Office for Health Systems Financing. And maybe I will hand over Lynn to you.
Thank you, Trin. Hi, everyone. My name is Lynn, and I also work for the WHO Barcelona Office for Health Systems Financing. I will be moderating the Q&A for today, so please make sure that you put your questions in the Q&A function down below. I'll hand over to Dan now.
Okay, and shall I share my screen, or have we got someone who can put the slides up for the session? Okay,
We got help for you. We got help for you.
thank you very much. That's great. It's the Russian slides.
In the upper bar, you can switch the screen then.
Yes, thank you. Got it.
Mhm.
Okay, so this is going to be not about people, but about money and the interaction of money, people, and organizations. The session that we have, we've got about an hour or so to talk about financing, different types of financing mechanisms and strategies that can help to support the integration and expansion of mental health services using the primary healthcare approach. So as it says here, we'll be covering a number of different types of topic. One which I will cover straight away is this issue of what do we mean by sustainable financing and equitable financing. We're going to hear about ways in which health benefit packages can be designed and developed and actually funded. The role of payment mechanisms and incentives to help or support or align with broader service reform goals. And also from the Czechia, we will hear about how community mental health services have been developed and expanded through external, partly with external funding support. So we already made the introductions of the moderators, and we will come to the individual countries. But to say that we've got three excellent country examples to illustrate some of these topics and issues and how these different countries have addressed health financing issues in respect to mental health service development. So we have collaborators and colleagues from Ukraine, Elisa Brizgalova and Olga Demeshko from the country office there. We have Kaya Kazakamp, who's a health economist based both at the University of Tartu and at the Barcelona office, along with Trin, and also Veronika Klimkova, a mental health consultant to the country office in Czechia and a public health policy and healthcare systems expert. Thank you so much for agreeing to join this session. We look forward to hearing your interventions in about 5 minutes. So if I could go to the next slide, please, just to get the ball rolling and introduce the topic. So I often put this up because it kind of just identifies some of the critical issues or questions that commonly come up and which do need to be, addressed in thinking about mental health system development from the financing and economic perspective. An obvious one to start with is the adequacy or sufficiency of funds. Are there enough funds available for mental health services? Commonly, the cry is no, there is not. So how to think about resource mobilization and for this sector is an important part of the financing question. But there's also a question of how well are resources that are already available put to use? Are we using the resources for mental health efficiently, whether in terms of the workforce capacities and competencies and availability, as was being discussed in the previous session, but also where is care located? Is it still the case in your countries that a lot of the budget is tied up with institutional specialized care? And if so, that poses a big challenge for the third of these items here, which is around the equity dimension. So how accessible is mental health care and services to people at the point of need? And how well are people protected against the the risk of financial hardship and out-of-pocket expenditures. This is a very important and often under addressed or under researched question. And then finally, to the question of sustainability. What do we mean by that? I will come to in a second. But how to ultimately ensure that the financing that is available or can be generated can be done so in a sustainable and equitable manner. Next slide, please. Next slide, please. Whilst we're coming up with that. Okay, thank you. So this is just to provide a bit of context to what I was just saying. In the European region, for example, you see here a graph showing the amount of mental health expenditure per capita, per head of population in US dollars. And you see this incredible range in terms of the amount of spending, ranging from below $10 in countries, including Ukraine, we'll hear from, even though they make incredible use of those dollars, that it's still inherently, absolutely a low level compared to what you see in some Western European countries. And the red dots above those bars are the estimated proportions of total health expenditure, that is a domestic health expenditure, government health expenditure that is allocated to mental health as a percentage. And again, ranging from around 2 to 10 or more percent. So this is the context in terms of what is actually being allocated and spent. And a second important point around the equity is the financial protection. So in the most recent edition of WHO Mental Health Atlas, we asked some questions about the extent to which people with mental health conditions or persons with mental health conditions are covered financially from potentially high out-of-pocket payments. And what we see is that there are particular issues around the payment towards medications, essential psychotropic medications, and even more so for access and use of psychological therapies. So you might have many countries have a situation where perhaps the inpatient care and maybe outpatient care is well covered by insurance or some other prepayment mechanism, but then there is still big gaps in terms of financial protection when it comes to the actual cost of interventions. Next slide, please. And then the final slide is just to introduce some of these strategies towards sustainable and equitable financing for mental health. And I think one of the important points to emphasize is that when we talk about being genuinely sustainable, that means domestic financing. Of course, development assistance, external assistance can have a very catalytic and helpful effect, but ultimately it cannot replace the function and the responsibility of governments to pay and protect the population, their populations in terms of domestic investment and financing. So I think that's one important point. And we will hear about the use of EU structural funds in Czechia as an example of that. But we will also hear about how countries are purposefully allocating more funding towards integration of mental health into primary care. A second strategy is around this financial protection and how to look at where the gaps in financial coverage or protection are and seek to develop policies that overcome those gaps and in coverage. A third one, which we'll hear around, is about using health financing as an integral part of system reform, UHC reform, health system reforms. So using, for example, targeted incentives or changes to the way that providers are paid as a means of moving the system forward. A clear example in Ukraine, which we'll hear very shortly. And then two more strategies are kind of going a bit outside the health sector, outside the mental health sector, and thinking about sources of resource mobilization for health in general. Brings us to topics like health taxes and other fiscal policies as a means of raising revenues. But even beyond those fiscal policies, an important constraint in many countries, particularly lower income countries, is suboptimal, weak public financial management, and sometimes also budget extension or execution, which is having an effect on the outputs of affecting the objectives and the outputs of a country's health system. So these are just some broad strategies, and we will now move into some country case studies that illustrate some of these strategies. So with that, I'd like to move to the next slide and introduce the first of our country case studies, which is Ukraine. And over to you, please, Alisa.
Thank you, Dan. Can we go to the next slide, please? And I hope you can hear me well. Yeah, thank you. Dear colleagues, Dan and Trine, it's a great pleasure to be here and to share our MHCAP experience, which has engaged us and inspired us for many years already. Can we go to the next slide, please? Thank you. And MHCAP in Ukraine is a story of partnership and continued and dedicated work of many stakeholders that was accelerated by political will and became a national-wide service available now for all Ukrainians in primary health care. Building this case over the years in Ukraine and going through a series of emergencies like conflict and then COVID and full-scale war, but also utilizing the momentum of great achievements and the reforms like health reform and the All Ukrainian Mental Health Program been launched recently. We have various lessons learned, and a few of them we are keen to share today with my colleague Olga. I would start with noting that historically, primary healthcare workers in Ukraine did not provide mental health care, and the launch of the new holistic primary healthcare concept by the Ministry of Health in 2017 created a strong opportunities and demand for integration of mental health services into primary healthcare. Through the MHCAP program, Ukraine achieved a fundamental shift in their mindsets of primary healthcare providers, doctors and nurses, who now demonstrate high confidence in delivering mental health care and increasingly doing so. The overall MHCAP rollout process in 2017 started with bringing partners together and using the momentum of primary healthcare reform. And we agreed the unified approach for MHCAP in Ukraine and started building capacity of trainers and primary healthcare providers. It took us 7 years to train almost 9,000 primary healthcare workers through coordinated effort of 29 partners and with an estimated collective investment of more than 6 million euro. And a second milestone development came with the engagement of the First Lady, and who prioritized MHCAP as part of her All Ukrainian Mental Health Program, launched to address rapidly growing population needs due to the war. And in support of this initiative, the Ministry of Health launched its first ever mental health service package in primary healthcare based on the capacity of primary healthcare workers built by WHO and partners. This package, together with MHCAP training and the national communication campaign led by the First Lady's program, greatly shifted the mindsets of primary healthcare staff who began providing mental health care for the first time. Last year, this standalone mental health package was merged into the core primary healthcare service package, and Olga will speak more about this. While a detailed understanding of how daily practices of primary healthcare doctors and nurses and about service user outcomes have changed, this all requires further investigation, but already today eHealth data shows a steady growth in service provided, with almost 1.5 million people received mental health care from their family doctors. So this was a brief snapshot of the MHCAP experience in Ukraine, and now I give the floor to Olga, who will share further insights on its financing aspects. Thank you, and over to you, Olga.
Thank you, Alisa. Do you hear me well? Yes. Good afternoon, colleagues. As Alisa already mentioned, in response to the growing population need for mental health services resulting from the war, Ukraine gradually introduced a dedicated mental health service package within the program of medical guarantees at the primary healthcare level, starting in 2022. Between 2022 and 2024, primary healthcare providers could voluntarily apply for additional contract with the National Health Service of Ukraine, which we call shortly NHSU, to deliver mental health services. To qualify, providers had to meet clear contractual requirements, including that both the primary healthcare doctor and nurse were trained in the management and treatment of patients with mental health conditions based on MHGAP principles. Providers received a monthly capitation payment per patient receiving mental health services with a maximum of 18 patients per PHC doctor per month. I'm sorry, colleagues, it seems to me that the slide was not changed for the one reflecting the reforms I'm speaking about. Could you please move to the next slide? Yes, thank you so much. So the payment design introduced, it created a direct financial incentives for primary healthcare teams to complete training and begin providing mental health services. It linked financing with the capacity building, which was a strong enabling factor. However, because the service package was optional, coverage remained limited and not all primary healthcare providers applied, and access varied geographically. That's why in 2025, mental health services were integrated into the core primary healthcare service package. The goal was to mainstream mental health care and ensure that all patients could receive basic mental health support at the primary healthcare level. By 2025, all primary healthcare providers had to complete the required training programs, and as a result, mental health service provision became mandatory for all NHSU contracted primary healthcare providers. This reform has necessitated the costing of mental health services, and WHO supported the NHSU in conducting a cost analysis of mental health services provision and calculating the associated labor cost within the annual capitation rate per patient. Importantly, under the new model, there is no longer a fixed limit on the number of patients who can receive services. Provision now depends on the size and the needs of the provider's patient panel and the payment on the size of the panel alone. The integration of mental health services costs into the annual capitation rate nearly doubled the annual income of primary healthcare providers for mental health services provision. NHSU funding for PHC mental health services increased from €108 in 2022 to almost 25 million euro in 2025. This scale up in financing was an important enabler of service expansion. Next slide, please. As a result, the service availability expanded nationwide from only 5 primary healthcare providers in 2022 to 2,671 providers in 2025. And also you can see from the slide that utilization increased fivefold between 2022 and 2024. This rapid scale up clearly demonstrates that financing policy can be a powerful lever for service transformation. However, changing the financing model in 2025 also presents some risks. We have observed that the number of patients with recorded mental health disorders in the e-health system declined in 2025. Integrating mental health payment into the general primary healthcare capitation rate may have unintentionally weakened incentives for either service recording or service provision. Without a dedicated payment for mental health services, providers may perceive mental health care as an additional responsibility without visible financial recognition. And capitation does not always reward the specific service outcomes and outputs, and may also create incentives to refer patients to specialists rather than manage them at the primary healthcare level. So this experience reminds us of an important lesson that payment design matters and financing mechanisms influence provider behavior, reporting patterns, and also service delivery. Next slide, please. To mitigate some of these risks, financing reform must be accompanied by strong non-financial measures. First, continuous supervision, mentorship, and professional support for primary healthcare providers in mental health care are essential. Training alone is not enough, and providers need ongoing guidance to feel confident managing mental health patients. Second, services must be clearly defined. The integration of MHGAP principles into national clinical protocols and patient pathways is critical to ensure clarity regarding the scope of PHC responsibilities. The third lesson is that standardized recording of mental health services in the e-health system is necessary to maintain visibility and accountability. And finally, systematic monitoring of service delivery is essential. We need both quantitative data on utilization, referral patterns, and expenditures, and qualitative insights from providers and patients. And only through continuous evaluation can we identify unintended effects and adjust financing policies accordingly. So the broader lesson is clear: financing reforms are a powerful catalyst for integrating services, but they are not sufficient on their own. And payment mechanisms must be carefully designed and continuously reviewed. They must align with clinical guidance, workforce capacity, information system, and governance structures. And perhaps most importantly, service delivery transformation takes time. It requires sustained investment, political commitment, and adaptive management. Ukraine's experience shows that even in the context of war, it is possible to expand mental health service rapidly at the primary healthcare level. But sustaining this progress requires the ability to refine payment design, strengthen non-financial support mechanisms, and closely monitor the impact of the reform. Thank you very much for your attention. Over to Trin.
Thank you so much, Alisa and Olga, for this super inspiring story from Ukraine. It's with such a Actually, Alisa, you mentioned that it's a kind of, it has been happening over a long period of time, but actually if we put like it's into other countries' perspective, like it's what Ukraine has been doing in a very short period of time, training all primary healthcare professionals, then like a scaling up financing and moving from a pilot phase to the system-wide implementation. It has been happening very, very rapidly, and of course, like it's at the same time in parallel, like a context where Ukraine needs to make progress with these reforms is extremely, extremely challenging. And thank you so much, Olga. Also, it's to reminding us that financing is important. And it does matter how we design financial incentives, and it is very cautionary. It's a story showing that if we are moving from targeted incentives to capitation-based financing, then in some country context where reporting is not so much it's a kind of part of natural culture of health professionals, it actually may undermine incentives for reporting, and we do not know does it really mean also that it undermines like it is how services are delivered to patients? And I think it's a very nice transition to our next country case study coming from Estonia. Estonia does have a longer experience with trying to shift mental health services from a psychiatrist level to the family doctors level and then the family doctors teams level, and using variety of different financial incentives with that. And I think it's with that one, I will hand over to Kaia to share Estonian experiences. Over to you, Kaia.
Thank you, Triin. Good afternoon. And indeed, I will talk about 3 decades of Estonian reforms supported by financial incentives of scaling up mental health services at the primary healthcare level. So something for which we have been taking 3 decades, but obviously, as you heard, Ukraine has put on the master speed and tried to do this. It's much faster. So for sure, very interesting to hear this Ukrainian experience. But to my presentation, please, for the next slide. The Barcelona Office for Health System Financing published a policy paper last year on increasing the role of primary healthcare in addressing mental health conditions, focusing also on financing aspects. So many of my colleagues here, Triin and Lynn, were engaged in developing this policy paper, but also many national experts. So my presentation in majority builds on the findings of this policy paper, but I do invite you to read more closely yourself. Let me start with the policy foundation. As Olga also kindly finished, financing cannot be in itself, and as financing is only a tool to support implementing policy objectives. In Estonia, the policy objectives have been grounded in frameworks that progressively have laid the ground for scaling mental health service delivery at the primary healthcare level. Firstly, starting with laying the basis for the health system, how it functions today in the country in the 90s. For example, reforming the hospital network and consolidating psychiatric care from monoprofile hospitals into multi-profile hospitals. Second, implementing a strong primary healthcare centered health system with family physician and nurse teams who are legally separated from specialist care. Then implementing requirements for referrals, although from the mental health aspects, psychiatric care has remained directly accessible. And expanding also step-by-step coverage for outpatient prescribed medicines. This has been the groundwork that has been done, what we call the first phase in this paper. But the second stage was actually the most important one when thinking of defining the policy framework and what then guides as a direction to introduce financial incentives in the system. So firstly, one of the most important frameworks we do have implemented at that second stage was the Primary Healthcare Development Plan, which introduced the concept of primary healthcare centers and multidisciplinary teams, as well as clarified the role of mental health care in primary healthcare. But the second one, a couple of years later, was the Psychiatric Care Development Plan, which as well explicitly emphasized strengthening primary health capacity to treat mental health conditions and improving collaboration between these two specialties. This laid a policy framework and supported the development of clinical guidelines in the field of mental health care. And this in itself also expanded the scope of services that could be provided at the primary healthcare level. And for example, the prescribing rights for mental health medicines as one of the examples. And the third phase was focused on implementing the defined policy objectives. Thus, the financial incentives were also in majority introduced at that period. And this is what I will focus on my following 2 slides. So next slide, please. So let me start with our infrastructure investments. Estonia used EU structural funds to build and refurbish primary healthcare centers that would allow to accommodate extended multidisciplinary teams, as priorly our primary healthcare system was very fragmented with mostly solo practices. And that was discussed also in the previous section, how this can be challenging when wanting to scale up mental health services at the primary healthcare level. To be eligible for these investments, co-location with clinical psychologists, mental health nurses, among other specialists, was encouraged. Furthermore, in order to support the move towards the multidisciplinary primary healthcare, the purchasing agency also introduced 2 changes in its primary healthcare financing and contracting. Firstly, it allowed flexible contracting arrangements for primary healthcare providers to support primary healthcare centers' development and to support expanding the scope of services provided by the primary healthcare centers. Secondly, also lump sum payments enabled hiring of additional nurses and also mental health nurses and extended mental health professionals within primary healthcare teams. Next slide. Expanding primary healthcare teams within the mental health with mental health professionals in solo practice-based model, I would say would have not been very simple. So these incentives that were put in place to have these multidisciplinary teams were quite crucial. And thus the upfront investments played a crucial role in such a large-scale transformation in our health system. But on this slide, you will see, I would say, a bit of a smaller scale financial incentives that the health insurance funds also put in place in order to scale the mental health service delivery at the primary healthcare level. You see here again 2 incentives. First of them is fee-for-service-based funding for clinical psychologist therapy with family physician direct referral. So prior to the reform of 2015, the clinical psychologist therapy services could only be accessed by a referral from psychiatrists. So in 2015, this was changed, and the fund holding for these services was given to primary healthcare providers. And you can see the impact here starting from 2015. There has been a significant increase of these services provided at the primary healthcare level. The second incentive that we are quite known for is the introduction of the e-consultation between a specialist and hereby between a psychiatrist and a family physician. So this strengthened the collaboration and allowed family doctors to manage more cases independently while receiving specialist input electronically. The e-consultations aim to improve integration between the levels of care, as the specialists needed to negotiate their role and criteria when e-consultation can be provided and when patients actually need to be referred to a specialist. And as you can see, also the number of e-consultation has increased over the years significantly. This can be a bit of a surprise in thinking why a family physician should use an e-consultation where there is no referral requirement for the psychiatrist. So why do not people just go directly? But actually this e-consultation has allowed a family physician to take more responsibility of managing mental health conditions, as well as it helps also to prioritize patients when there are severe conditions, and quicker access to psychiatrist services may be needed then a patient would get one just directly trying to book an appointment with them. Next slide. Despite of these described reforms, still quite some challenges remain in our system. For instance, although the primary healthcare provider's authority to prescribe treatment for mental health conditions was broadened, and that the growing share of these selected mental health medicines are now prescribed by family doctors, these medicines are often still not unaffordable. For instance, an average of 10 euros spent on an antidepressant per patient, 4 euros is covered for the person in Estonia. Approximately 6 euros is paid out of pocket. 5 euros from this is from compulsory, quite high fixed and percentage co-payments that we do have. And 1 euro is an avoidable co-payment from reference pricing system that we do use, which this co-payment could be avoided when patient could choose the cheapest medicine in the pharmacy and would be advised to do so. Thus, an important challenge remains. Challenges remain. A significant share of medicine cost is still paid out of pocket. As mentioned by Dan in the beginning, we also have a challenge that many people in Estonia are not covered by the insurance. So they do have access only to emergency mental care. But we know with severe mental health conditions, it's quite difficult to keep your continuous insurance coverage when you may be in and out of jobs because of your mental health conditions. As well as long waiting times are a continuous issue in Estonia for psychiatrists and psychotherapy. It's a huge issue. So many people who have the opportunity choose to pay privately for these services. So this mental health care and treatment affordability is a major policy concern in Estonia. And this is making the point that only scaling services at primary healthcare level does not automatically ensure better and more equal access, and that more should be done. And now I come to my key lessons or key messages. Next slide. So firstly, based on Estonian experience, large-scale investments may help to support big transformation in the healthcare system, such as these investments in the infrastructure to make it fit for the purpose. Secondly, targeted financial incentives can effectively help to support primary healthcare centers' mental health services, such as seen in the increase in psychotherapy sessions provided at the primary healthcare level, or growth in the e-consultations allowing to take primary healthcare to take more role. Thirdly, financing reforms must address also both service provision and financial protection without reducing the co-payments and coverage caps. Equity challenges in service access persist even when delivered by primary health care. Lastly, but most importantly, like also Olga concluded, a clear policy framework is essential. Payment reforms cannot substitute strategic direction. And what we have really learned in Estonia is that ensuring clinical leadership in the reforms and securing buy-in is crucial, especially when you are trying to transfer responsibilities from psychiatric care to primary health care. So thank you for listening about the Estonian experience, and I very much look forward to the discussion and give the word back to Triin. Thank you.
Thank you so much, Kaia, and thank you really highlighting the importance of different clinical specialists like psychiatrists and family doctors, how important it is that they are collaborating, they are agreeing the roles, so it's what is the role of family doctors, what is the role of psychiatrists, but also highlighting the importance that financial incentives are aligned. So it's in a way that bringing this e-consultation example, so it's the financial incentives as well as, like I say, desire to encourage family doctors and psychiatrists to collaborate more. They like it's more like it's aim for the same health system objective, and you can see also here this UHC watch slide. So it's those who want to Lynn put into the chat as well, like a policy briefs, but all these policy briefs are available also in UHC Watch platform. In addition to that, you can find like it's a country's financial protection, health spending data, and also useful information on how coverage policies are organized in the UHC Watch platform. But coming back to Kaja's presentation, Kaja started with and also later on highlighted the importance of capital investments, and capital investments, especially if the aim is to have a larger scale service delivery transformation. And also like it's mentioning that EU funds are used for that. I think it's a very like it's a good like it's a transition now to Czechia's experience, what Veronica will share with us. But now we are shifting like it's from primary healthcare that is led by family doctors to more like it's a community mental health centers, and that is more like it's aligned with the institutionalization agenda, how we can like it's bring care closer to people's home and instead of delivering care in an inpatient setting, but in outpatient setting closer to people. And that is what also Dan mentioned in the introductory presentation, that it's really serving these equity goals as well. So without like it's a further ado, Veronica, over to you.
Thank you, Trin, and thanks everyone for joining and for sharing all these interesting and inspiring experiences from across the countries. Because I have to say, just like Kaja was finalizing her presentation, even I'm going to name some points that you've already heard today, and I think we're going to have a rich discussion on some common points and maybe some potential differences across countries. So I would like to navigate you or guide you through the Czech case where the European Union funds were used to transition the care that was typically traditionally provided in inpatient psychiatric facilities into the community, and how the European Union funds were fundamental in accelerating this change. And then later we're going to see some challenges that might be involved in this case. So next slide, please. Let's have a look at the policy challenge of the country. So looking back to 1989, we will see that very similarly to other countries in the Central and Eastern European region, even the Czech Republic started its transition to the care in community only after the revolution, which was in this year. And the early attempts were rather fragmented. The political and financial support was rather suboptimal or lacking. We could see that the mental health services originally weren't really covered from public health insurance and mostly relied on grants. There was a huge health and social sectors divide, and use of data for either monitoring the situation or really taking responsible decisions was not routine practice, unfortunately. You also see on my slide that I want to mention persisting stigma, and this is a challenge that the country has been dealing with ever since, unfortunately. But an important turning point for the country came in 2013 with Strategy for Psychiatric Care Reform. That was the main national strategy document that was published by the country's Ministry of Health. And the objectives or the vision of this strategy was clear. We want care that is provided to people, so that is person oriented. We want care that will help to overcome those challenges with persisting stigma and lack of coordination across sectors. And we also want to have care that is able to prevent some of those issues already in the community or closer to the environment where people live, so that we can really detect and see the challenges in the start. So before we actually have those mental health disorders already rampant in the country. I want to say that in the period between 2017 and 2022, the country was, I would say, lucky because it managed to earmark European Union funds. And here I'm specifically talking about European structural and investment funds that were really fundamental in making this first transition, making the first steps. And it was also aligned with the political commitment of the then government that saw it as a great window of opportunity and an incentive to really start the reform process. At the center of this change stood community mental health centers. Their aim was to reduce long-term hospitalization, to improve functioning of patients, and to increase their quality of care, but also to tackle exactly those challenges that I've already mentioned. And if you ask me about real service affordability, I have to say that based on data and based on what we see in the country, this has not been the most fundamental barrier to accessing the care. And the country, similarly to what already has been mentioned here, primarily has to deal with lack of professional capacities, especially child psychiatrists, but also long waiting times, stigma. So next slide, please. Let's zoom in on the community mental health centers. In the country, those centers serve to cater for patients and clients with severe mental health conditions. They are built around multidisciplinary care teams. Those are psychiatrists, clinical psychologists, general and mental health nurses, and social workers. They ensure continuity of care so that the client really, after leaving the facility, the inpatient facility, smoothly continues the necessary care and support in the community. And the services are also tailored specifically to the needs of the individuals. There are also some specialized services for diverse populations. This may include services focused on young children and adolescents, but also older people or people with substance use disorders. So those are all on offer in the country. To start such a change, and as we'll see later, even to sustain it, joint leadership of many ministries is necessary. In the case of the Czech Republic, naturally, the Ministry of Health has been always involved, but also the Ministry of Labor and Social Affairs, because that is responsible for the social component of care. And specifically in Czechia, also the Ministry for Regional Development. That was the ministry that was mainly administering the projects related to building the health infrastructure, but also for later building or developing other premises and places where people could be treated, and their refurbishment, of course. As you can see on the slide, the real establishment of those centers occurred in 3 phases, so that there were 3 projects that aimed at developing them. So it was a gradual process. It didn't happen from day 1 to day 2, of course. And after the implementation period, at the end of the implementing programming period in 2022, the Ministry of Health already secured negotiated contracts with health insurance companies. So at least the health component was already covered through public health insurance. However, when it comes to the social component, as I'm talking about it in this division that still persisted, that was financed through regional funds and regional allocations, all being under the responsibility of the Ministry of Labor and Social Affairs. By 2024, the country already had 36 community mental health centers, because the ministry also managed to secure additional European funding. But as you can see and well understand from the ambitious vision of the country, it was still below the initial target. and that has been set for 1,000 community mental health centers. A part of the problem, or a part of the issue with transitioning to the domestic funding, was exactly this division between the two sectors. And while the healthcare component has been secured, unfortunately, the social component was relying on varying contributions of the regions, and this also led to varying quality of care and patient outcomes, also further exacerbating the equity of in access to care. Next slide, please. But I, of course, want to stay positive because the impact has been very, 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 very huge. And first of all, I need to mention the rapidly growing service use. You can see on the first graph on the right-hand side of all that the number of clients of the community mental health centers increased from around 300 in 2018 to more than 6,000 in 2022. So that is exactly the first implementation period. This is also a signal that even the demand for these services increased, not only their accessibility. And when it comes to hospitalizations, we can also see some positive trends, especially in short-term hospitalizations, which is also visible on the second graph, that they declined especially in the implementation time. Important is also the impact on the patient and their quality of life, mental health, overall mental health, and daily functioning, which got better. And this has been measured through standardized instruments, mainly the Health of the Nations outcome scales. But during the time of the use of services, which was the period of 12 months, clients also reported greater participation in work-related and volunteering activities. So even this aspect was bettered. There have been a lot of positive shifts in public attitudes towards people with mental health. Unfortunately, and I need to restate that, more has to be done in terms of discrimination and stigma, even despite large-scale campaigns already ongoing or having been ongoing. The country also has to tackle other issues such as changing priorities at a highest political level, which was also due to changes in the political governance. So that might have been something expected slightly, but it also shows that sustaining the support in the long run is fundamental, which again was already mentioned even in the previous presentations. And what is encouraging here is that we have seen some good initiatives already taking place, especially when it comes to supporting the further professional development of the healthcare workforce, especially child psychiatrists, so funding their trainings, even trainings of nurses, and also institutionalization, but of the community mental health centers, so that they are legally recognized, and each team that creates the new centers has some standards on the personnel and material equipment needed to start a service. And I would like to ask you for the last slide, where I would like to recap the lessons learned. So as you can see, having a national strategy is essential, but having a strong and sustained political backing is also fundamental. Upfront investments in infrastructure and also trainings is likewise very, very important, but the transition to domestic funding might be challenging, and this might also reflect the division in roles and responsibilities between the two or more sectors that are involved. Again, something that I'm restating from other presentations, provider payments and incentives have to be aligned with the reform goals or the strategy goals. Also, which is visible in the Czech case, the social and health component. And that might also create some unnecessary insecurity for the regions, for providers, and also for the patients who are looking for the access to care. Cross-sectoral collaboration requires alignment and coordination. This is also relevant to how they function in daily on a daily basis, basically how they share information and how they collaborate, how they are managed because there are dual structures, and what the funding sources and streams are. So I hope that these lessons bear something that you might take to your home countries and maybe, draw some inspiration, even disregarding what the sources of the funding were in your case. But I hope that there are some lessons to be learned. On the last slide, I'm just sharing some milestones of the entire reform and shifting the Czechs' psychiatric care or mental health care that was later provided more, or gradually, increasingly more in communities. Thank you very much for your time and attention.
So wonderful. Thank you so much, Veronica, and to all of the other the country speakers. Indeed, I think lots of information, but lots of inspiration as well for participants of this session to take away. And the good news is that all of these case studies have actually been written up, and Lynn has been popping those into the chat. So if you want to know more details about any of those three experiences, you can find them there. So we're running a bit low on time and not going to have much time for discussion. So I suggest that we may perhaps have time for one question per country, and then we pass it over to Trin to summarize where we got to in this session. So we finish in a timely manner. So what I'd like to do first, before passing to Lynn, is perhaps just ask Elisa and Olga. I mean, the change has been so extraordinary and rapid, and I think my question is around the speed with which things have happened. So you were talking about 5 primary healthcare providers in 2022 having been, and now we're looking at nationwide coverage, and we see these incredible statistics coming in of the numbers of people trained. So maybe you could elaborate a bit on what that took. I mean, what enabled that, but maybe also a bit like business is growing so fast that sometimes they go bust. I mean, what do you see as potential risks given the speed with which things have happened around, for example, the quality of care? Over to you. Thank you. Just short answers, 2 minutes max.
Thanks. Then this is challenging us. Actually, we have indeed many lessons learned, but also on the threats to the process as well. So I would prioritize probably few enablers in our case, in case of Ukraine. First of all, it is comprehensive preparatory work, as we started in 2019 with translating the tools, training the trainers, and setting up the scene for the national-wide scale up. Then I think timing or momentum, how we call it, and using the momentum and political will also of the government and the first lady. Leadership of the healthcare workers themselves, which is key as they become themselves trainers and roll out this basically themselves within their community with some support from mental health specialists. And partnership. Partnership is key, as no single agency can address that need in the size of country like Ukraine. And final one is probably innovation and agility, as we introduced some range of measures like online course and others in digital tools to speed that up. And in terms of threats or like barriers, of course we have many as the process is quite complex, and one is, for example, remaining barriers in the current regulation, which cannot allow currently us to fully roll out mental health services in primary healthcare, and we're working with the ministry to address those. And also probably some financial constraints faced by some partners, which also happens. Yeah, thank you. I think that's it from my side.
Thanks so much, and congratulations. I know you've been so key to all of this, and it's been remarkable to witness. Over to you, Lynn, to ask other colleagues.
Thank you, Dan. Thank you, Dan. And thank you everyone in the chat for being so active. My question is actually directed to Kaya. There was one question in the chat about the Estonian results and how it was very impressive to see the graphs that you posted about the e-consultations. But basically, the question was about elaborating on how the coordination and the care pathway was operationalized in practice, and were there any implementation challenges? If you can briefly tell us your experience.
Thank you for the question, and indeed, this has been a challenge in Estonia, as we do have a huge lack of psychiatrists in Estonia, so which has pushed us to do reforms. So we just don't have enough of them, and granting just access to psychiatrists without the primary healthcare referral has resulted in significant waiting times. And we have seen in the past also that for these specialities where we don't have these compulsory referrals, these waiting times tend to be longer. So in order to reduce the waiting times, the consultation has been one of the policy measure. And why I personally do like it, and why I want to emphasize it, is that when introducing an e-consultation, the specialities need to come together and agree between themselves the rules. When patient can obtain an e-consultation based on what health status, and based on what health status this patient actually can be or needs to be taken over by a psychiatrist, and in what circumstances this patient actually needs to be transferred directly to emergency care. So this e-consultation process, biggest benefit has been making these specialities to discuss this and agree upon these pathways for patients. But nonetheless, I need to mention that when comparing overall share of referrals to psychiatric care, then e-consultation nonetheless are still marginal. So not all family physicians still use e-consultation only. They do also, even if they don't have to, they do also just regular referrals and transfer patients to psychiatrists. But we hope to scale it in the future even more. Thank you.
Thank you, Kaya. If I can quickly revert to Veronica, because we have barely any time, but basically to reflect on Kaya's answer, do you see similarities or differences between the Czech case and the Estonian case? Kaya spoke about waiting times, lack of psychiatrists. How do you see this in the Czech scenario? In a quick minute answer.
Of course, I see many similarities, as I also said during the presentation. And indeed, when we look into the unmet need of the country, it's not really a problem of the affordability of the services, but rather the long waiting times and stigma that is also involved. And in practice, the Czech public health system is very generous. Health insurance system is very generous. That means that when you come to use the service, it's free of charge for you most of the times. For most of the services. But in effect, in reality, sometimes when you have to wait long, or when you are afraid to present yourself at a doctor's, you might still be disadvantaged. And some households, and we also have data for this, have already felt discouraged. So this situation already pushed them out of the public system. So they have started to look for private providers. But this is naturally, this can be the case of everyone, because there are also vulnerable populations that can't afford that. So this is something really to look into. And maybe I would just highlight the critical role of GPs and primary healthcare that needs to be supported or strengthened, so that we detect the issues, the mental health issues already in the beginning, and we can prevent people's mental health from deteriorating and maybe needing more specialized care, which is lacking in the country. But we are still working on it, and the change seems to be positive. Thank you.
Thank you, Veronica. And with that last minute, I really want to thank you, Dan, Lynn, Alisa, Olga, Kaya, and Veronica. And I think these country examples, what we shared in this session, and it was really beautiful to see that the lessons learned are really like what are emerging are really similar. So it's the importance of payment incentives. So it's from Ukraine example, like it's how like it's starting with targeted incentives, starting to scale up, then integrating into capitation payment, and then it's a kind of, we all know that capitation payment doesn't like incentivize recording activities, and then we see it happen in real time. So it's really like it's monitoring how payment incentives are impacting activities, gives us also possibility to make adjustments. And there, like it's the Estonian example, really using like relatively sophisticated targeted incentives. One new emerging policy objective, how can we incentivize by using financial incentives? So it's really, really nice combination. And then also reminder for us that it's a one thing how we pay for services, but if we want something larger scale service delivery transformation, to shift care from inpatient to outpatient setting, to shift care to primary health care, and to introduce multidisciplinary primary health care, it's regular payment incentives might not be enough, and upfront investments to the infrastructure, digital infrastructure, health workforce training, all that is also needed to support that effort. And I think like it's for me, like it's the third, like a takeaway message is really efforts beyond financing are needed. Sometimes we really think that let's change financing and then like it's things start to happen. But really what is needed is political commitment, policy framework, collaboration between like clinicians and clinical leadership. In addition, so it's many like multiple efforts really are needed. It is needed that these multiple efforts are aligned, and then like it's really financing becomes very powerful instrument to support all this reform implementation. And I think this is like it's the finish of this session. With that, we have 15 minutes break. Please come back like it's after 15 minutes, because we have a super interesting session on how digital technologies are used in mental health, what are opportunities there, what are challenges. So we will continue with our discussions. So thank you very much for being with us, and see you in 15 minutes.
So welcome everyone. Thank you for joining us this last session in this mini conference. I thank you for your stamina. My name is Zulfiya Pirova, and I'm Technical Officer at the WHO European Center for Primary Health Care. And I'm joined today by my colleague, Dr. Kim Yu. Kim, please introduce
Hello,
yourself.
everyone, and thank you so much. My name is Dr. Kim Yu. I'm a family physician. I'm also liaison to the WHO from WONCA, the World Organization of Family Doctors. Truly a pleasure to be on here. Back to you, Zofia.
Thank you. At today's session, we talk about digital technologies and how digital technologies can improve access and facilitate quality of care. So we brought distinguished panel, distinguished guests today, and this is our panel members, which we will go in about 15 minutes. And before that, we will have a keynote presentation laying ground for this discussion. So during the panel, we will ask our guests to share some examples from their practice, how the digital technologies help them to improve patients' access to care, to help clinical decisions, what is the evidence, what is work and where's the best evidence, and also what practical, ethical, and safety consideration we must have in mind before for adoption of the digital technologies in primary health care. For those who just join us, a very brief piece of housekeeping. Please watch chat for instructions on language and slides use. If you have any questions to the panelists or to keynote speaker, please them in Q&A. We try to pick up as much as possible. And without any further ado, I over to Kim to introduce our keynote speaker. Kim, floor is yours.
Thank you so much. I'm so proud and honored to introduce Dr. Viviana Martinez Bianchi, WONCA president and also director and professor of clinical and community engagement at Duke Family Medicine. And Dr. Martinez Bianchi will be talking about harnessing digital technologies for mental health, the role of family doctors and primary care. Viviana, over to you.
Thank you, Kim. Let me start sharing my slides. Let me know when they're visible. Can you see them? They are? Okay, so let me get started. Good afternoon, good evening, depending where you are in the world, or good morning, colleagues, friends, and partners. It's an honor to join the World Health Organization in this important conversation. I come to you today as a family doctor, an academic professor involved in caring for the community, and as president of WONCA, a very proud colleague of many family doctors around the world and primary care teams that I know are watching today. WONCA represents more than 500,000 family doctors in 7 regions of the world. And I want to begin not with technology, but with a patient. A young woman comes to see a family doctor in a clinic, in an office. She tells the doctor that she's not sleeping well. She feels constantly anxious, overwhelmed by work, by family responsibilities, by everything happening around her. She says, "Doctor, I can't quiet my mind." They talk, they explore what she's going through, they discussed options. She did not need medication at that moment, but she needed support. Some type of support, she says, that she could access every day in her own time. So together, they explore a digital tool, an app on her phone that can guide her through breathing, relaxation, and meditation techniques. Simple practices, accessible, always available. At her next visit, she shares, "Doctor, I use it at night when I couldn't fall asleep. It helps me sleep. I feel like I have something I can do to be able to relax." It did not replace care, but it extended it. It extended it into her daily life. Across the world, family doctors are the first point of contact for most people with mental health needs. And often, we are the only point of care. We see mental health every day in chronic diseases, in maternal care, in adolescence, in aging. We see it in the context of families, communities, and lives. In many countries, primary care is already the main provider of mental health services. Yet, demand continues to outpace that capacity, while access to specialized care remains limited. Long waiting times, workforce shortages, and fragmented systems leave family doctors managing increasingly complex needs, often without sufficient support. This is where digital technologies offer real promise, expanding the reach of primary care while preserving the human core. Digital technologies are no longer theoretical, they're already improving care. Integrated into primary care, they help us identify mental health needs earlier. For example, through digital assessments completed before visits that start with alerting us in real time that the patient coming in may have some suicidality or severe depression concerns or severe anxiety. They do not replace care, but they strengthen it. They enable earlier identification, faster access to support, ongoing monitoring, and greater patient empowerment. In this way, they extend the reach of family doctors beyond the consultation room. We are now seeing strong evidence that digital mental health interventions can work. For example, online collaborative care models combining computerized cognitive behavioral therapy with internet-based support have demonstrated real effectiveness. They offer 24/7 access to care while helping reduce the stigma that still keeps many people from seeking help. We're also seeing a strong engagement of people in the we are seeing some studies where patients use mental health apps more than 90 times an average, even among underserved populations. This tells us something important. People are willing to engage with digital tools when those tools truly meet their needs. Supporting clinical care. Digital tools can also strengthen the work of family doctors. Patients tell us that tracking their symptoms helps them communicate more clearly with their clinicians. And when we can see what is happening between those visits, we are able to make more timely decisions, adjusting care, including medications, including referrals to more intensive behavioral support in a more precise and responsive way. This allows us to move from reactive care to proactive continuous care. But let me be clear, digital tools do not replace clinical judgment. They support it. They enhance the relationship. They do not substitute it. The challenge, however, is implementation. We must acknowledge a critical reality. Despite growing evidence, adoption remains low. Only about 19% of clinicians currently recommend mental health apps in their practice. And even when digital tools are integrated into health systems, only a small proportion, about 14%, actively are using them. So the challenge is no longer innovation. The challenge also is implementation. Bringing these tools into real-world primary care where they can truly make a difference. So what is holding us back? We are seeing consistent barriers across countries and across practices. Digital tools are often not designed for the realities of primary care. They are not well integrated into clinical workflows. They are not connected to electronic health records. And too often they are time-consuming to use. Family doctors need tools that fit within their practice. They need tools that do not add to their burden. We also face important gaps in training. Many clinicians have not been supported to use digital mental health tools effectively or confidently. And concerns about privacy, safety, and data protection remain significant for both clinicians and for patients. Equity is also a defining issue. We must also be clear that digital health can either reduce inequities or actually worsen them. In primary care, we see those who are often left behind, people in rural areas, migrant communities, people with limited digital access, those facing social and economic challenges. If we design digital tools for the average user, we will miss those who need them most, those who are not considered to be the average users of technology. Equity in digital mental health must be built in from the very beginning. It means designing for language, for cultural relevance, for accessibility, and for connectivity. Because we know this, primary care is where equity becomes real. If digital transformation is to succeed, we must invest also in the primary care workforce. Family doctors and their teams need training in digital mental health, integrated systems that truly support care, and team-based models that allow this care to work in practice, along with the time and infrastructure to use those tools effectively. Primary care must be equipped, not overwhelmed. To get this right, we must invest in family doctors. We must invest in the training of primary care teams. We must invest in the entire primary care workforce. And importantly, family doctors must be co-designers of these solutions because they understand the complexity of the patient's lives. They understand communities, and they understand what works and what does not at the point of care. I'm excited to know our incoming speakers are going to be addressing this from their perspective and also from other members of the team as psychologists. Digital technologies also offer an opportunity to empower patients, but only if they are simple, intuitive, relevant, and co-designed with communities and patients themselves who are telling us what they want. Tools that fit their lives, education, flexibility, respect for their privacy and dignity. Digital mental health must be people and community centered. At WONCA, we represent more than 500,000 family doctors across over 130 countries. We are uniquely positioned to bridge global policy and local practice. We can support implementation of digital mental health in primary care. You're going to hear from Ana Luisa Neves, one of the leaders in digital technology for WONCA. We can extend our work with community health workers and other members of the team, share lessons across countries like we're doing today, build capacity and training, advance equity, and we stand ready to partner with the World Health Organization and member states to ensure that digital innovation translates into real-world impact. Imagine a system where mental health needs are identified early in primary care. Patients receive support without delay. Care is continuous, not episodic. Primary care is connected, supported, and strong, where digital tools enhance, not replace, human relationships, where technology serves people. We embrace community. There is no health without mental health, and there's no mental health without primary care. If we want digital mental health to succeed, it must work where people receive care, in primary care, with family doctors, in communities, and care together in teams. Let us move from innovation to implementation, from technology-centered solutions to people-centered care. And this May 19th, let's celebrate together World Family Doctor Day. Our theme this year, compassionate care in a digital world. Thank you very much for this opportunity to open today's panel on digital health.
Viviana, thank you so very much for laying such a beautiful foundation, for setting such a beautiful scene for our discussion ahead. And in some of your presentation, I've seen that you said that primary care is a home for mental health. And so let's have discussion on this background. how to make our home more accessible and safe, how to bring services to those people who are in need, and how to facilitate this. So with this, let me move on with the first round of our discussion, and where we would like to ask panelists to share some examples, practical examples from their work, research work and practice, how digital tools help to connect primary care to have faster access and support to mental health services. And here I would like to turn to our guest, Helene Rieper, Professor of Mental Health at the Department of Clinical Psychology, VU University Amsterdam from Netherlands. Helene, your work at the VU Amsterdam has positioned you at the forefront of the e-mental health research in Europe. And with digital technologies evolving so fast, from guided self-help tools to AI-driven therapies, could you share with us what is the current evidence landscape? What is the strongest evidence across the continuum of care? And what opportunities does it give to for primary healthcare providers to improve access to services and support people in need? Helene, please, floor is yours.
Thank you. You seduced me to talk very fast because I've only 4 minutes to describe this landscape of digital mental health, which has evolved over the last 25 years. I first would like to thank Viviana for her very nice presentation. If you want to delve me into the evidence base of digital mental health, I think in primary care, I think we need to first take into account that primary care is very differently organized across the globe, even in Western societies. And for example, I'm from the Netherlands, and when we talk about primary care, it's not only the family doctor which is covering the issue of providing mental health treatment, but we have also first line psychologists, we have public health, mental health nurses who support the family doctor, so to say. And I expect my colleague Tim Olde Hartman will touch upon that issue, so I leave it by here. But let's say if we have a very first have a look at the services available, digital mental health services, which could be employed in primary care. You can think about unguided interventions, so interventions without the support of a human health professional. Actually, that one is built into the software. You have guided interventions on a distance, so you are guided by a professional, but not face to face. We have blended formats, which take most of the time take place in the clinic, where you combine face to face and digital solutions. And you have, for example, since COVID, also video-based conferencing, which provide direct contact between a health professional and a patient, but it's synchronic in time. Now, the majority, we have worked hard over the last 25 years to establish an evidence base, and that evidence base is mainly developed based on randomized controlled trials and meta-analytic work for the unguided and guided interventions for the common mental disorders. The complex psychiatric patient population is a different one, but let me address those who have suffered from common mental disorders. And the evidence for those unguided and guided interventions is robust. So we can say both forms are better than non-intervening, so they do better. And when you compare it with active treatment, that's the core component of a control condition of a randomized control trial, they far as good as the face-to-face interventions. And I think that's very important for primary care, the vast majority of those type of interventions, randomized controlled trials and studies, are conducted with populations which are recruited from the general population. So it are not actually patients who knock on the door of their primary care physicians or the primary care psychologists, but that those are patients, or they are not patients, they are members of the community, so to say, who suffer from a problem and who are looking out for help either by social media or otherwise, or from within a primary care facilities. But the services offered are not provided, so the studies by those working in primary care, nor are they direct primary care patients. There are studies like that, but they are very few. So I think the first task we have to do. It's of course much more difficult to do randomized controlled trials in healthcare settings, and especially, and Tim, I hope you will address it in primary care facilities, more even than in specialized mental health services. So we have evidence both for compared to non-intervening, for example, for depression and anxiety, and compared to active treatment components, but the actually knowledge of primary care patients who knock on the door of their physician is still scarce. And I think I'm almost on my 4 minutes, but I want to address the issue of Viviana, because on top of that, you do not only look at is it effective, but also has it negative side effects, for example. We do not find that in a higher degree than face-to-face treatment. But I really think on top of to have more randomized controlled trials in family practices or primary care, the main focus should be on implementation, because we assume, given that the profile of the patients who we recruit from the general populations are rather similar than those to primary care. Most often they are more highly educated, so we need to oversample, say, people from a lower social economic background, or maybe with more comorbidities than only mental health problems. But this integration in mental health service provision, that is largely understudied, and it is worldwide. You have front runners countries, you have countries who still have to develop those type of interventions. This implementation as an integrated component on the workflow, I think Viviana called it like that. I think that is a major challenge we all face, and that's actually the black swan of the last 5 years. The implementation has increased also in primary care, but it was due to COVID, because we were forced to provide more care on a distance, while 20 years before, despite all our effort, it's proven to be a main obstacle. So there's all the promise also for primary care, and it has to do with education and training, but I think we must put much more attention to implementation science and to make it part of routine care. I think I'm now in the 4 minutes. Eh?
I think you exhausted
Yeah.
all the time. But
Okay.
thank you very much for sharing these insights and very interesting findings. And I want to bring in Tim here. Maybe he can tell us more. Tim Olde Hartman is a general practitioner in the academic research practice Oosterhout and head of research unit at the Department of Primary and Community Care at Radboud University in Netherlands. Did I say it correctly?
Correct.
Okay, so Tim, you bring here this dual unique perspective as a practicing physician. a general practitioner and as a researcher, and in your daily work, you see the struggle of general practitioners, what challenges they face supporting people with patient needs, as also mentioned by Viviana. So what barriers in your practice led to explore use of digital solutions, and do you have any lessons learned how to implement these technologies? Could you share with us, please?
Yes, of course. Thank you. And I'm honored to be here in this panel. Yeah, much of my, I'm a 2.5 days a week general practitioner and 2.5 days a week researcher. So I combine both worlds. And most of my projects start with the struggle I experience in my daily practice and by curiosity about being curious about why is this happening. And I would like to highlight two of the recent projects we are doing. So as general practitioners, but also as patients, there is a lot of struggle to navigate the complex and fragmented care landscape that there is in mental health. We started to build a regional digital and staffed platform to help citizens, patients, and professionals to find the right mental health care. This digital platform was across social care, primary and secondary healthcare, so mental health care. And it had the aim to improve access to information and care for citizens and patients with mental health complaints while reducing the burden of professionals. And it was a really successful project. As well, patients as family physicians could find this workshop or this digital platform and were guided to the right care they needed at the right moment. So it delivers a lot of transparency and knowledge about where to find the right care. Another project that was about depression care and the development of an app in order to introduce more lifestyle treatments to patients with depressive symptoms, because GPs often lack practical tools to effectively guide patients toward appropriate lifestyle. In the treatment of depression, within general practice, lifestyle-oriented approaches, they are still underutilized. So what we did, we searched for a way to come to data-driven care in a personalized lifestyle treatment of depression. In that project, both GPs and patients they indicate that they received insufficient feedback on the effectiveness of the initial treatment, and an app could help them with this feedback. So we aimed at systematically collecting and using patient-reported outcomes and relevant health data in order to feed back these data to the GP and to the patients, with the goal to improve the integration of lifestyle interventions into depression care. And it's amazing how patients and doctors react on this intervention. It's a very easy to use app. We built the app together with the patient, so because that's, I think, really important. And we also asked opinions of patients about this app, and this is very, very recently analyzed. We are now writing a paper on it, but patients indicate very much that blended care is important. So the app should function as a supplementary support, as clinical contact remains, according to them, essential. So that's important. That's a clear patient opinion. They value the fact that they receive feedback and evaluation about how they are doing, and the possibility of setting goals within that app. The app should offer them guidance. It motivates them to pick up the task they have to do with regard to lifestyle, and it provides them a lot of insights and evidence-based information. And they also view that the fact that professionals are able to monitor them within that app helps them a lot. They have also a couple of requirements. Such an app should be very easy to use. It should be simple to install. It should be visually very clear, and it should be written in accessible language, which is, I think, very reasonable. But they also have concerns, and we will come back later on that. But the app, for example, cannot act on suicidal thoughts. there is an increase in screen time, which might also have side effects, and they also worries about privacy issues. So that's the side of the patient. So these are two digital projects. One about a better overview of the healthcare facilities that there are in getting help for their mental health use, and one very much into practice between doctor and patients in order to improve the depression care.
Thank you so much, Tim, for sharing. Indeed, it's very interesting lesson for implementation, what aspects we need to consider when we want to introduce digital technologies. And with that also, I would like to turn into Ana Luisa Neves, who is a clinical associate professor in digital health and director of Global Digital Health Unit at Imperial College in London, and also chair of the Wonka Working Party on e-health and digital health. Ana Luisa, so your work at Imperial College and your leadership role in Wonka e-digital health party, working party, give you visibility into digital innovations internationally. And what from your perspective, how digital platforms and applications support primary care settings in terms of scaling up services? And do you know if any opportunities are identified to reach out populations that conventionally are overlooked by conventional mental health interventions?
Yeah, thank you so much. Thank you so much. It's a very important question. And first of all, it's a pleasure to be here. Thank you so much for the opportunity. So I think you're absolutely right. And just picking up on some of the points raised by Viviane and Tim and Helene as well. What I think we see from a global perspective is that, and in the UK as well, of course, is that digital mental health seems to be more and more oriented towards a systems approach rather than an isolated solution. So what we know is that for these solutions to be effective for primary care, they need to be articulated, integrated, and even from a data perspective, information needs to flow so that care can be provided in a way that's continuous and that provides value for the user. So what we are seeing here in the UK, and it's obviously a case for many other countries, is that in countries where primary care actually acts as a front door to the health system, and particularly in this case, thinking about mental health care, that creates a lot of opportunities for primary care, but it also creates a lot of pressure. And what we are seeing in mental health services globally is that due to that increasing pressure, which can be justified by a range of reasons, workforce shortages, increased complexity of the population, we are seeing more and more delays in mental health care or access to mental health care. And thinking about your specific question and about populations that have been, I wouldn't say neglected, but maybe less studied, I think a really interesting case here in the UK and in many other countries is to use digital mental health services to target young people, especially teenagers, young adults experiencing anxiety, and depressive conditions. And these groups of people are typically experiencing very long delays between the moment where they ask for help, they reach primary care services, and they eventually receive the mental health care that they need. So one of the places in which digital health solutions have increasingly been positioning themselves is trying to bridge this gap. So going back to Viviana's point, not replacing the care that we know needs to be there and that needs to be human-bound care, but to act as a transition tool for people that are waiting for services that already sought help, but were not still able to get into the system. So some examples that I can share with you here from the UK. So there's one project in which I'm personally involved as well, which is called Mindcraft. So not Minecraft, Mindcraft, which aims to serve as a tool that young people can use to navigate the system as they were waiting. So let's imagine they reached out to a primary care physician, they've been referred, but what happens in this gap? And it has been built, and we have published a few things around this project, and is ongoing now as well. We have used it in different populations, even in schools as well. And the idea is to try to give this support to young people, which goes through educational resources, which goes through a social community, which goes as well through webinars and sessions with specialists in mental health to inform them more about those conditions. And what we found it was really interesting, and another component that we also built there as well is to actually give children and give young people the opportunity to actually develop their own content and validate that content with expert professionals. So what we have seen is that, as you can imagine from a research perspective, we are always very concerned about safety issues. So we get something like this out. How do we create a safety net here to make sure that things don't go wrong? And from that perspective, most of these interventions originally focused on low-risk patients for the obvious reasons. What we saw was that actually, when we started to explore the results in further depth, the greatest benefit was actually experienced by young people that were actually towards the high-risk area. So that actually shows that some of the prejudices that we might have about who would benefit most of these solutions can potentially be challenged. So trying to go back to your point of what can we do to serve better these underserved populations, there's a point that was raised by Tim, and I would just like to reiterate: co-design, co-design, co-design. Again, we cannot keep pushing solutions into the system that are designed by academics or clinicians or social scientists or all of us together. The patient needs to be at the center, and they need to have a voice there. And we have seen that with so many technologies that have just, went through our daily lives, large language models, social media. There was no training for us to use it. There was no facilitation. So they are solutions that A, are easy to use, and B, serve a need that the population has, even if they are not aware of that need. But when the solution gets out, is perceived as relevant, is user-friendly, is designed with the user as its core value, that's really the key thing that we need to keep in mind if we want to ensure the very important point that Viviana mentioned before about the successful implementation. So if I were to summarize, and just mindful of time as well, my key points for successful implementation for vulnerable populations: co-design, as I mentioned, cross-collaboration. Again, these solutions cannot be standalone. If they are standalone, they will be just another floating piece of the puzzle that really is not adding as much value as it could and maybe should. And the third one, and that's a bit of a fluid environment at the moment, is regulation and governance and ethical frameworks around it. And this is true not only for digital mental health, this has been true for many other solutions, including digital scribes, for example, which are an excellent example of how technology sometimes just moves faster than regulation, gets back to people's hands faster than we can assess its safety, equity, quality, and broader impacts. So although one can argue that's maybe not much that we can do to stop the wave, I think there is a moral imperative that we are very aware of those risks and at least try to mitigate them as we go.
Thank you so very much for outlining this so comprehensively. In the interest of time, let us move to our another speaker. Kim, over to you.
Thank you so much. In terms of safe and ethical, effective implementation, we have Ana Maria Tejerino, the Technical Officer in Mental Health and Wellbeing Unit for WHO Regional Office for Europe. Ana Maria, the WHO Regional Office for Europe has been working intensively with member states to understand both the tremendous potential and the implementation challenges of digital mental health interventions. Through this work with front-runner countries, you've gained insights into what it takes to create an environment where these technologies can be safely and effectively embedded in health systems. So what are the critical foundational elements that member states need to establish, and what opportunities do you really see for other countries to build on this experience?
Thank you very much for your question, Kim. And probably what I will say now, it's going to resonate so much with what all or my previous colleagues from the panel have mentioned. And I think that's very coherent in the sense that I think we are going in the same direction with the narrative that we want to bring and with all these blocks that we want to where we want that they are in place to support member states in that sense. So we have done inspire and under the principles of our regional digital health strategy. We actually took those principles and put them together and in collaboration with the Department of Health of Ireland in a series of different consultations with key member states, which usually are those front runners, as you call them, key on how they have advanced digital mental health technologies and how they have embedded them into policy and into a wider structure. And some of those reflections that came out from those conclusions are helping us to draft what we hope to be publishing soon, which is the WHO Europe Digital Mental Health Roadmap. So we'll hope that this will give countries and member states those foundation blocks to move from, doesn't matter in which level you are of implementation of your digital mental health technologies, to actually scale up in a way that is safe, that is equity, and that is reaching most of the people that we want to serve in a safer way. So some of these key points is that anchor digital technology in policy needs to be a must. It cannot be a side project. So they need to name it, they need to own it, and connect to a broader mental health and digital agendas, even before the formal instruments are in place. So sometimes it's true that the instrument is there and the policy comes later, but we are pushing very strongly that needs to be anchored in a wider policy. And this needs governance. Without leadership and accountability and as well clinical oversight from the start, things get fragmented. So good intentions become pilots that they never scale at the end. So we don't reach a proper implementation on these interventions. And one thing that Ana Luisa mentioned, and as well Viviana, is standards and regulations. These are not bureaucracy, these are protection. And recently we just finalized a few weeks ago a community knowledge platform on actually understanding what regulatory mechanisms need to be in place, specifically for digital mental health technologies, because we do have some coming out for medical technologies, but not something specifically for digital mental health. So we got very nice insights from the different stakeholders that participated in this knowledge community. And it was clear that we needed not a big accountability from producers, from users, also from the practitioners who are the ones who provide this technology, but also not only the regulation first, but also the post-market surveillance and when changes need to be acknowledged for these regulatory bodies. And another aspect that I would like to highlight is the infrastructure needs to connect and not to be a silo. So the digital tools only work when they talk to the rest of the system. So to the care pathways, to the data, to the different people delivering care. So that needs to be also one of the fundamentals of these key aspects of developing digital technologies. Already mentioned, but I will do it again because that's what our communication support officer says. If we repeat the messages, it stays. Workforce training and live experience involvement are non-negotiable. So if health workers are not confident in using the tools, and if the people who use them haven't shaped them, then adoption, implementation fails. So this is also another foundation that we want to put into this roadmap. And finally, I would like to point that we need to acknowledge the duality of digital spaces. Digital environments, they offer real opportunities for connection, support, and access, but they also carry some risks. So any responsible digital mental health strategy must navigate this reality and not just the opportunities of digital mental health technology. I think I stayed in my 4 minutes. Thank you very much, Kim, and I'm looking forward for continuing this panel discussion.
Thank you so much. And so much of what you say, we've heard like policy importance and the ability to really not have these silos and to ensure that we have the training that we need, which is definitely non-negotiable. Moving along, Dr. Ana Luisa Neves, your dual role as a researcher at Imperial and as chair of Wonka's e-health working party positions you to really see the intersection of innovation and implementation across diverse health systems. What opportunities do you see for digital technologies to actually advance health equity rather than widen existing disparities?
Thank you so much. It's the question, isn't it? It always reminds me back on time when I started work on digital innovation, so 15 years ago or so. One of the main concern really beyond regulation was the concept of digital divide. So we are doing something to help people, but we know from the very beginning that those that are going to adopt it first and most likely benefit from it are those that come from more advantaged social backgrounds, higher literacy, better places. So we knew and we know from definition that digital innovation, when you launch it, when you implement it, is going to help advancing those that are already in a better position. And as you mentioned, Kim, very well, entrenching, aggravating, widening these existing disparities. So I would say that this is still a pretty much central concern in digital innovation and in mental digital innovation as well. I would say that given the progress and adoption that I've seen over the last 10 years, and most importantly, seeing all the surprisingly good examples of how different layers of the population have deconstructed our idea that the digital divide was a blocker. I think the future looks promising, really. So that reminds me of a range of classic barriers to adoption that we use to recognize. We use very typically to say older people, they will struggle to engage with technology. And what we saw, both from an adoption perspective and also from a social perspective, and research backs it up, is that people from older ages with the right support at the right time, they do equally well. And I think that's a very humbling message. It's a very humbling message because if we think about someone with 80 years old, which has been through so many different versions of the world that we know and has adapted and has grown with it and has made the best of it, of course they can do it. They just need to support. And I think we have seen really interesting messages from research and from society in generally around what is this digital divide, which of course is a concern, but from my perspective is a concern that we need to address positively rather than label as necessarily a blocker. So these are really long way to go to say that I think there are really interesting opportunities for us to keep addressing, keep considering that divide and how we can build it, but also to use technologies as a tool to actually improve that divide. And the obvious applications are in first place thinking about areas that are more isolated, population that don't really have the same healthcare resources or number of healthcare professionals that others might have. If we think about telemedicine or digital health or care at distance in the very beginning, the concept and the vision was literally to give that kind of care, to give that kind of support to those populations where they could reach out to a specialist or to someone else, healthcare provider that could give them care at distance, advice at distance, and give them the care that they should have if all the resources were located equally. So one of the first opportunities for improvement in equity is this bridging this geographical gap or these geographical disparities. Another angle in which I think it could be really interesting to keep exploring digital innovation to reduce inequities is around resource mapping and coordination of care. So I talk a little bit about digital bridging this gap when people are somehow a little bit more lost or delayed in the system. But if you think about concepts such as task sharing and task shifting, which classically we were thinking about how to share or shift tasks between professionals. Actually, now we are sharing and shifting tasks with technology as well. And I don't mean technology on its own. I don't mean technology leading it, but technology augmenting it, supporting it, enhancing it, and maybe also releasing the workforce so that workforce can dedicate time to other tasks where a human is required and the human cannot be replaced. So this is another second aspect in which I think equity could be an opportunity as well. And I would like to maybe end up with a bit of a more global perspective, because we've talked a lot about regulation, and I'm not going, and I couldn't, and I would never dismiss the importance of regulation. But I also wanted to flag that regulation, or let me put it the other way around. There's also very interesting cases of countries that started a little bit later on digital innovation. And because regulation is developing alongside, that actually presents interesting opportunities for them to leapfrog and to develop things better and more agile than we do. So we are literally comparing systems that are developing innovation and implementing innovation, as Viviana said, with a legacy infrastructure that might be adapted or not. And we have other systems that are developing the regulation in an agile way and have the opportunity to be more responsive, more adapted, and maybe more fit for purpose. So I think that's a really interesting opportunity globally that we shouldn't ignore maybe as well.
Thank you so much. And I know that Wonka has perspectives on those global standards and best practices for, having co-design with inclusiveness and evidence-based regulation without stifling the innovation that we so desperately need. Moving forward, Dr. Hartman, Tim, you have been addressing, how do you think we should be addressing data privacy and information sharing between the app, the patients, and family doctors? And what opportunities do you see really for understanding the impact on patient outcomes and general practice workload and healthcare utilization in everyday practice?
Yeah. I'm not a data and privacy protection specialist, so that's I'm just a general practitioner. So that's quite a difficult question. But for example, in the Netherlands, these kind of apps they should fulfill the general data protection regulation, and they should have been certified ISO and NEN. So there are quite a lot of rules to put such an healthcare app into the wide space. And our patients within our Lydia's trial, they also, their key concerns was that they stressed that data security must be guaranteed. So users may feel skeptical or distrustful about sharing personal information online. So it's really important that this is a key issue that we should address very much. When we look at our Lydia Australia, we want to evaluate the effects and the cost effectiveness of using such an app with all kinds also of secondary outcome parameters, like what's the influence on the use of healthcare resources, including psychological care. Excuse me. The app is built together with a company, Interactive Studios, which also has a really big platform with extensive experience in working in healthcare settings. So more than 90 healthcare organizations like hospitals and university medical centers are clients of them, and they work according the latest standards of security and privacy with all kinds of certificates related to information security, and processing of medical data. The storage of those data from the patients in the Netherlands, that they are stored within a fully certified Microsoft data center. So with the confirmation that the data does not leave the European economic space. So there are all kinds of regulations in place to keep the data secure. And yet the whole platform and the patient journey app, which is the app which we use, it's considered as a medical device. So it's also registered under the MDR, so the medical device regulation requirement. So but I'm not a specialist on these kind of things. But when we started the whole project, this were our main questions with regard to the company. Okay, how secure are the data, and how secured is the whole thing with regard to the patient? So yeah.
Thank you so much, Tim. And, we are running short on time, but I do want to ask Helene, in terms of regulatory frameworks, it's really crucial in determining which of these innovations reach the patients and how quickly. What opportunities do you see for regulations to safely accelerate the scale up of these digital health technologies in primary care? Unmute, please. Unmute.
That's a rather, we could write a thesis about this question. But what I think what is very important is to make a distinction between who is offered the mental health service. So we cannot go for a quick fix. We cannot do that with pharmacology or with face-to-face treatment. So I think partly we need to follow the generic regulatory framework which is at stake, in addition to more the digital mental health requirements in terms of privacy and data sustainability and all those things. And I think what you can maybe take as an example, which is I think mainly now developed in the United States, is that from digital interventions to reimbursed intervention, we now talk about digital therapeutics. And that means that the frame and the rules they need to fit in needs to be acknowledged by all the relevant stakeholders and have a place in the clinical, the mono or multidisciplinary clinical guidelines as well. But I would like to end, and that has nothing to do with regulation, but it is actually to do with what Anna said, because I really, when we talk about the digital divide in the digital mental health domain, I think one divide is underreported or underrepresented, and that's a digital divide between men and female mental health. Because if you look at all, that's different from somatic health, but when you look at our domain, it's the users are 75 to 80% women. The people who provide the support or the treatment are women. So I think there is a huge challenge to see how we can cross the digital divide between genders as well, so that also let's say men and other gender types can also benefit to the most of the potentials of digital mental health. And I find it very important, given everything what's going on in the world and the unmet needs of many men in mental health. I think that is a challenge also between West and East and North and South.
Thank you so much. There's so many amazing things that have been discussed so far, and trying to distill it all in one sentence is very difficult. But I really think that talking about digital divide, meeting the needs of patients where they are, providing the right care at the right time, in the right place, all of that really speaks to the importance of primary care and the work that is done both by doctors, nurses, psychologists, psychiatrists, everyone in this space to provide the best mental health for our patients. We're going to move to question and answer. We don't have enough time to be able to answer all of these questions, unfortunately, but I did want to touch on the one that was mentioned about ChatGPT. Quick thoughts from folks about ChatGPT and the use of that in addressing mental health needs. I know, Viviana, you mentioned something.
Yeah, so I think there are several issues that are important to think. Why are people turning to ChatGPT for therapy is the first thing that comes to mind, right? And we are seeing this globally. I mean, I was just at a restaurant the other day, and a friend, not a medical friend, is showing me how ChatGPT was helping her, and I'm thinking, wait a second. Hold on. Have you talked to your doctor about this? Have you talked to a? Well, she goes, there was a long waiting time. I couldn't get in. So I think there's a reality. There's a shortage of mental health professionals. There's high cost. There is the convenience and immediately off the ChatGPT app. there's reduced stigma. People can go and tell them, I feel depressed, I'm down, whatever, I'm feeling like I'm crazy, whatever is it that people are saying. So I think it's responding to a difficulty with access. The issue, I think, the very significant risk is that ChatGPT is not therapy. It does not diagnose mental illness. It doesn't understand the full clinical context of what's going on in the patient. It doesn't replace the human therapeutic relationship. And so there are real concerns of missing a crisis situation, suicidality. I just was posting on the chat. I just noticed Instagram will start sending parents alerts if there is suicidality, which at least as a family doctor, as a primary care provider, if a child that is a teenager talks to me about suicidality, I will talk with this person and say, hey, I think it's important at this point to go and talk to your parents about it. Let's talk about a family approach to the issue of suicidality in a teenager. ChatGPT is not going to do that. So I think it's very important. And also is what is the evidence that's supporting this? And I see Helen has more
Yeah,
comments
because
about this.
I fully agree because we are at the birth of the use of ChatGPT, but of course there are many, I say, different possibilities combining generative AI with specialist AI. And I really think, so I agree with all the concerns, but I think we are entering or we are in the middle of the AI world. So my message to all psychologists, psychotherapists, therapists, be on top of it. And the world changes. And I don't think we have to look at AI from our old discourse, and AI will read my lips, will change mental and healthcare service delivery and will replace, how you say, some services. Not yet, and the evidence needs to be there, but it has this capacity to talk in natural language. And if you talk about the digital divide and the algorithms are well developed, it opens. I'm a little bit afraid that 25 years of work of our unguided and guided interventions will become outdated very soon because we are able to enlarge our mental health services with natural language, visual and textual phrases. So we can warn from the dangers, which is good, and then more research is needed, but it's already more around us, and it's not only generative chat GPT. So I'm actually looking forward to a very exciting new development in our field with all concerns, right? But
I look forward to AI technology that is fed by evidence. If you search on something on ChatGPT, it will quote from Reddit. It will grab things from
I agree.
So that's
But
I'm hopeful, you know, and Ana Luisa was referring to this and she has her hand up, and I think there's so much but we have to
I
participate
agree.
in building it.
That's the point, yes.
Ana, está muda.
Muda, perdón. So yeah, I was just listening and reflecting, and there's two key words that are coming to my mind. So of course we're discussing this issue with use, misuse, or suboptimal use of ChatGPT. But the first one, the real problem is access, is lack of access, because people are going to other alternatives because they don't see other way. And this may be the core problem here. And the second point, just to be very short, very brief, is what we are doing at the moment as a society is off-label use of technology. We are using technology that's not for specific medical purposes, but we are using it for medical purposes. And yeah, I think we'll see some interesting developments moving from ChatGPT to open evidence and more tailored solutions that might help you. And I'll finish here.
Thank you. I'm going to give Sophia final closing remarks, please. Thank you for our panelists.
Thank you very much. And unfortunately, we don't have time to continue these very exciting discussions, but I think we have many more opportunities ahead. So thank you very much for joining this very interesting conversation, staying with us online and being present here. So thank you very much, and we invite you to the closing briefing. Very brief closing. Sorry. And we will be happy to hear from you as well. We have very interesting piece I heard. Thank you very much, everyone. Over.
Thank you. Thank you.
Thank you very much, everybody. And those of you, many of you, in fact, who are still with us, please give yourselves a very big applause for your stamina and commitment to really immerse yourselves, right, in policies to integrate mental health services and primary health care. So we have come to the end of this very rich mini conference. We have only spent 8 hours together, but I don't know about you, Lydia, but to me, it feels so much more because we have heard so many inspiring country stories, country narratives, very clear strategies, policies with evidence and impact. So this has been a very rich 8 hours, and I learned very, very much. We would like to draw on you one last time to help us sum up this very rich 2 days. If you were to think of one word when you think of scaling up mental health services in primary healthcare, what would be that one word? Take out your phones, scan the QR code you see, and type away. Give us that one word. And while you're fiddling with that, Lydia, do you have one word with which you can sum up these 2 days?
I certainly do. But I would like to start, Melita. When we started planning for this conference, you were adamant of calling it mini conference so that it was not a burden on the audience. But I think also another reason was that we were at the end of last year, we were overwhelmed with work, and by putting the word mini conference, we hope to sweeten the deal and make it seem more doable and easily done. But I think it's a disservice to call this a mini conference because, as you said, the richness of the discussions, the depth of the discussions is amazing. And also, I am flattered as a WHO staff, I'm flattered at WHO Europe staff that we had participants from all over the world. So thank you very much to all those that stayed with us for those 2 very interesting days. Before I go to my last word, I'll share with you. We talked as professionals, as policymakers, as researchers, as academics. Let's put ourselves in the shoes of the patients. If we are a patient of a primary care center, can you figure out where is the hospital that you went as children to take care of your own health, of your parents' health, with your grandparents, and where is the primary health care center? And I'm sure in your mind you'll be able to visualize how the hospitals are very likely the same and in the same places and with the same functions they have been always, while primary healthcare centers have evolved in terms of not only location, but also functions, but also innovation. And why is that? Because primary healthcare is the most natural pillar of healthcare that follows the trends of an ever-changing society. So we live in an ever-changing society where trends are changing, and primary healthcare is the best place to not only reactively follow an ever-changing society, but also proactively precede change. So ever-changing is my keyword. Melita, back to you.
Thank you very much. And I am really pleased that you put such an emphasis on people, right? Because we started this mini conference by thinking about people and committing to service design around people. So that was a very, very nice. And we are indeed in a very fluid and ever-changing world where these 2 very powerful trends of strengthening primary healthcare, but also community-facing mental health, community-embedded mental health services, deinstitutionalization, demedicalization are happening at a faster and faster pace. So that's very apt. So let's look at what our participants saying. What is their one word? The big words jumping out at me: integration. Very important, very hard to do, but we looked at very interesting country models, financing instrument, health workforce policies, and ways of working together. Because we know from our experience that when we integrate, it's not enough to put people with different backgrounds, different training, professional ethics, and belief, to put it into the same team. How we work together and develop an organizational culture is key. I'm seeing equity, a big yes. How much we talked about vulnerability, and we really dug into that question very much, and we can do more. In our primary healthcare team, we have very, very strong tools how to identify vulnerable and people and complex people in the population through better health management tools. So please do reach out to us for that. There is huge opportunities. I'm loving that the word empathy is coming out here so strongly, and this is going to relate to my word. We will come back to that later. I'm seeing coordination, collaboration, and future. Maybe I'll stop on that word. You can all read a bit more into it, but I love this last panel because it really put us into the future. We heard so much in the past 2 days about what has been done, and I'm really admiring the what has been done, but also really thinking about the digital tools and what's possible and whatnot is really putting us into the future. So with that, let us go to my word and truly closing this conference. My word, and I'm slightly cheating because it's really 1.5 words. It's a mindset shift. We need a mindset shift not to see primary healthcare and mental health services as separate worlds. A mindset shift to see how they belong together. And it connects so well to what you said, Lydia, and to that word in the chat. It is about seeing people as whole human beings, not as separate diagnoses, not as fragmented problems, but as individuals whose physical, mental, and social health are deeply connected. And when mental health is part of everyday primary healthcare, care becomes truly continuous, relational, and grounded in people's lives. And we know that this is what builds trust. I don't know if you all knew, but in 2 years, in 2028, we will be celebrating the 50th anniversary of the Alma Ata Declaration on Primary Healthcare. And this holistic, people-centered vision was indeed was the heart of the Alma Ata Declaration. But truthfully, it has been quite difficult over the past 50 years to make it a reality. But when I listen to these stories over the last 2 years, these country narratives, we are seeing the Alma Ata Declaration in practice. And I hope when we mark the anniversary in 2 years' time, we will be able to bring these wonderful narratives of integrating and scaling up mental health services in primary healthcare settings to show how the Alma Ata Declaration can truly work in practice. And to close, after these 2 days, one thing is very clear to me. We know what to do. We have very clear strategies. We understand which approaches work. We even have evidence. We know how to strengthen the workforce, how to fund services sustainably, and how to leverage digital tools in a way to help people. Country after country has shown us what's possible with a real impact on lives. What we need, however, is continued advocacy and sustained investment with primary healthcare and community mental health clearly prioritized. And for that, we need champions. And our champions are you, all of you out there who are championing for this greater and better world. All of you are change agents. And thank you so much again for your time and commitment for being here. We hope that these last 2 days have strengthened your commitment. They have armed you with tools and evidence to continue championing the scale up of mental health services in primary healthcare. We are deeply grateful to our partner Wonka for bringing this event together, and to all partners working through the Pan-European Mental Health Coalition who work really tirelessly to translate ideas into action. At WHO, we are wholeheartedly with you and ready to support you and work with you with the clear commitment and true passion of our regional director, Dr. Hans Kluge, for the cause of mental health. Although you see Lydia and me to open and close, the real lift for this event was done by our core team who moved all mountains to bring together the best evidence and experiences. I would like to thank our team, Dr. Zulfia Pirova, Anna Sagan, Anna Maria Tijerino, and Cassie Redlich for their tireless efforts over the past few months. And with that, thank you so much for being here, and let us continue to hold this flag and carry it forward together.
Thank you all.